The committee will come to order. Good morning. Today, when a family faces a sudden illness, a chronic health issue, or a life-threatening accident, their first thought is fear for the health of their loved one. Their second is to worry about how they will afford it. When concerned about their health, patients don't want to be contestants on a game show trying to guess which hospital door leads to the lowest prices. Yet they frequently lack access to the price of a medical service before they receive it. Without greater price transparency, patients are in the passenger seat of their healthcare decisions. We want them to drive it. More than 2 years ago, President Trump signed into law the No Surprises Act, which contained consumer protections against surprise billing. It created a historically significant transparency tool for patients and advanced explanation of benefits, or AEOB, to explain the cost associated with care before it ever takes place. And yet, so far the administration has not implemented the AEOB program, keeping important information from patients and families. We remain hopeful that we can achieve our bipartisan goal of protecting patients. Why did Congress and the Trump administration prioritize this effort? Because price transparency works. In the past 20 years, the prices of medical services increased by 130%. Meanwhile, other shoppable commodities, like TVs, for example, decreased by nearly 100%. Transparency and competition deliver better results. We have seen the price of shoppable healthcare services, such as LASIK eye surgery, decrease by 20% over the last 15 years, while innovation and quality have increased. That's not a coincidence. Instead of keeping patients in the waiting room for real reform, we should pursue further price transparency tools to lower cost. According to one estimate, less than 25% of hospitals are fully compliant with President Trump's historic price transparency rules, and those are just the ones reviewed. To date, the Centers for Medicare and Medicaid Services has only fined 4 hospitals for noncompliance. 4 hospitals. There are 6,000 hospitals in the United States. Do we really think that nearly every American hospital is in compliance? We don't know because CMS doesn't make compliance reviews and enforcement actions public. We can get more information about a local restaurant from Yelp than you can get about your local hospital from CMS. Cash-strapped patients in dire situations need to be able to easily compare prices and decide for themselves where to get care. And lawmakers and innovators alike need to be able to see these trends with real data that will enable us to see where further reforms are needed. Americans want to know, and they have the right to know, what their health care will cost. Price transparency has support from all over. Just a few weeks ago, I met with rapper Fat Joe to hear how he and his community are advocating for this very effort. Healthcare price transparency is crucial, but other reforms will also ensure patients can get better value for their dollars in healthcare. For example, tax advantage health accounts, such as health savings accounts, allows patients to better save for medical expenses. When combined with the true upfront knowledge of prices, this can be powerful for families to plan and budget. Yet certain patient populations, including working seniors on Medicare and service members and their families on TRICARE, are excluded from using HSAs. Outdated red tape prevents certain innovative healthcare delivery options for patients and employers using HSAs. We should make these types of accounts easier to use, not harder. A health emergency should not become a financial catastrophe. I'm looking forward to a bipartisan discussion on how to increase price transparency to strengthen our healthcare system and empower patients. I will now turn to the ranking member, Mr. Neal, for the purposes of his opening statement.
Thank you, Mr. Chairman. I want to thank our witnesses for appearing here before the committee this morning. Over a decade ago, Democrats transformed American health care with the Affordable Care Act. More Americans have health care coverage than ever before. 135 million Americans with pre-existing conditions have protections. Women are no longer charged more than men. And this committee's premium tax credits put an average of $2,400 a year back into family pockets. Thanks to the investments and work of this committee, with Democrats in Congress and now with Joe Biden, the 2023 open enrollment season was the most successful in our history. Over 16 million people enrolled in coverage through the marketplace. Absolutely life-changing and the type of success we could only dream of when we made the ACA a pillar of our healthcare system. Meanwhile, the other side continues to double down on challenging our accomplishments, proposing draconian cuts, stripping Americans of the coverage that they rely upon. Their latest attempt to take away Americans' health care would put 21 million Americans on Medicaid at risk of losing their coverage. A reminder, 56 cents on the Medicaid dollar goes to nursing home care. It has been 12 years and we still haven't seen a comprehensive health care plan from our colleagues on the other side. Just repeat efforts to criticize what it was that we did. Republicans have never agreed on health care in all the years I've been on Congress. They have not provided an alternative, ever. So while we can't speak to their goals or their plans, I think we can see through what they're attempting to do. Today, we are going to promote transparency along with health savings accounts, high-deductible health care plans that promote consumer shopping as a way to lower health care costs. But pushing more burdens onto consumers and expecting them to navigate the red tape at a time of vulnerability only tilts the field against patients and will result in even more medical debt, which I still believe is the largest cause of bankruptcy in America. Patients already have skin in the game when they seek medical care. We want to improve their health. This approach exacerbates disparities and contributes to the unsustainable medical debt that's become too pervasive throughout our country. Relying on just transparency and shopping to solve our health care challenges is only part of the potential that we have to improve the system. We want what's best for our patients, and that means an accessible, affordable, and transparent health care system with robust protections for consumers. Democrats on the committee have been approaching this transparency from every angle over several years. We've pushed for better data collection to make more informed policy decisions for our nation's seniors, and we've sought to better understand the impact of private equity in health care. Back in 2021, we worked together to provide consumers with more transparency when we passed the No Surprises Act. I am enormously and immensely proud of what Kevin Brady and I were able to do at that time, and it continues to stand up to challenges in courtrooms, and Kevin and I have indicated we still intend to be witnesses at the right moment in proceeding cases. Since 2021, hospitals have been required to publicly post standard charges and negotiated rates for common health services and procedures. This committee has led the charge with bipartisan efforts on drug price transparency. Another major push for transparency came out of the drug pricing provisions of the Inflation Reduction Act, where Democrats stood up to special interests and put an end to profits over people. Insulin is now capped at $35 a month for seniors, and soon Medicare will be able to negotiate on drug prices, giving our seniors the peace of mind knowing what they can expect when they visit the pharmacy. We should not pretend, however, that transparency shopping alone is the magic of the marketplace. We are going to try to fundamentally address coverage gaps, medical debt and cost burdens, and health inequities. Democrats will continue to support those provisions. We want to make sure that the improvements in transparency may help around the margins, but we know we likely will have to go much farther in making sure that consumers actually have access to affordable, dependable, and comprehensive coverage that won't leave them high and dry in a time of need. So that's what this committee should be focused on, not on serving special interests and powerful industry players. We want to make sure that sicker, poorer, and more segmented America is returned to good health, and that's what I hope we will hear about this morning. With that, I yield back the balance of my time.
Thank you, Mr. Neal. I will now introduce our witnesses. I want to thank you all for taking time out of your busy schedules to be here. We're very grateful and appreciative. Our first witness is Kendi Troiano. She is the Human Resources Director for Clark Grave Vault Company. And we have Ron Pinecki, is the co-founder and medical director of Wellbridge Surgical. We We have Christopher Whaley, who is a professor at Rand Party Graduate School. We have Bill Campine, is the co-founder and chief innovation officer of Healthcare Blue Book. We have William Short, is the executive chairman of Ameriflex. And Rick Gilfillan is former CMMI director and former CEO of Trinity Health. Ms. Troiano, you are recognized.
Good morning. Thank you for inviting me to be here today. My name is Kendi Troiano, and I am the Human Resources Director at Clark Great Vault Company in Columbus, Ohio. For 125 years, Clark Great Vault has manufactured steel, stainless steel, and copper burial vaults. Our company employs 114 people, most of whom are in Ohio, though we have company's employees in 11 other states. Most of our employees are blue-collar workers with a high school education or GED. Our company is made up of 98% men who range in age from 18 to 67. I have worked at Clark for 26 years, and I am responsible for managing all human resources and employee benefits. But I am here today to talk about our healthcare insurance and why we believe price transparency is so important. During our annual renewal for healthcare, we were told our premiums were going to increase 35% because of one large claim and two claims that were between $20,000 and $30,000. A 35% increase was not feasible for us or the employees. The cost of raw goods have increased, and we cannot continue our current cost structure when costs continue to increase at such a high rate. We knew there had to be something available to allow our employees to shop for the cost of health care, just like they shop for a car, dishwasher, or other personal items. We decided to switch from our traditional health plan to a new kind of health plan called Sidecar Health. We were seeking a long-term partner that could lower health care costs without jeopardizing quality or access to care. My employer values being able to offer generous benefits to our employees, and as a two-time cancer survivor, I need the security of knowing that I am covered and that I can afford my health care coverage. Maintaining the coverage that is affordable to both the company and the employee is very important to our company. We chose Sidecar Health for our employees because their model is designed to give consumers control over cost and choice. Their plan allows us the freedom to choose any licensed provider who accepts cash or credit card because we are not constrained by networks, formularies, or prior authorizations. We are provided a budget or benefit amount for any medical need and allows us to choose a provider based on that budget. It is our choice to stay within the budget or pay out a little bit more, sometimes about the amount of a copay. When we find care for less, we keep the savings through a credit. For the first time, we have the kind of price transparency needed to shop for care. With Sidecar Health, we can engage with our healthcare system the way we do everything else in our lives and pay for care at the time of service. Employees have a credit card tied to the Sidecar Health account to pay their expenses up front without tying up their cash. In addition to the savings we see as a company, our employees also see savings at the provider's office and the pharmacy. For example, my husband's oncology visit last year was billed to my insurance company for $233. Through self-pay, I paid $100 for the same visit. His lab work went from $80 per visit to $30 per visit for cash pay. Prescription coverage is costing me $44 every 3 months instead of $115. A procedure for one of our employees decreased from $4,500 to $2,000. Our employees love the prescription drug coverage, and they can utilize mail order services or online coupons. Both generic and brand prescriptions are covered under Sidecar Health. By shopping through Sidecar's website, they know how much their costs are going to be before they go to the pharmacy, making them informed consumers. It's no secret employers pay the highest rates for health care in the U.S., but these investments often do not result in better benefits for employees, not anymore. Sidecar Health does not compromise quality or access. Healthcare providers have been programmed that the only way to have health insurance is to negotiate with insurance companies for discounts, bill them, and wait for payment. Sidecar Health is changing that by paying the provider in advance using a cash discount. We believe very strongly that our employees are consumers of healthcare and need access to pricing information and data to make intelligent choices. No one should be denied access to knowing what services cost in our healthcare system. For years, we tried to find a company that would provide us care and feel we have finally found that partner. People shop when they purchase furniture, cars, or services, yet they cannot price shop when they search for their healthcare needs. We feel it is vital that our employees know what their healthcare costs them and the company. By knowing the cost beforehand, they make the choice to remain within a budgeted amount or spend a little more. Knowing the cost in advance brings them power to choose how to spend their healthcare dollars. Thank you again for the opportunity to testify today, and I look forward to your questions.
Thank you, Ms. Troiano. Now, Mr. Pinecki.
Good morning. I'd like to thank Chairman Smith and the committee members for the opportunity to speak here today. My name is Ron Pinecki. I'm a clinical anesthesiologist in active clinical practice in Indianapolis. Have been doing so for about 13 years now, and in the past part of a private physician group environment prior to starting the business that I'm currently a co-founder in, Wellbridge Surgical. My motivation for being here today is based upon my frustrations and disappointments within the current health system. I'm not alone in that view, although I guess I'm the representative for that view here among physicians nationally. Basically, that frustration kind of came about with a series of questions that I got asked by patients. Not long into clinical practice, patients began asking simple questions in the pre-op consultation before surgery. Are you in network with my network, or do you know what the cost is for the services that you're providing today? And I spent tens of thousands of hours learning how to provide clinical care, but I didn't spend a single minute in residency or medical school training learning how to answer that question. So I felt it was somewhat my responsibility to be able to have a decent answer. And so that kind of started the journey to kind of figuring out, hey, how does the system work? Where do the costs lie? And what are my actual charges to any individual patient? So 6 years ago, I was introduced to the Free Market Medical Association. That association is a group of physicians and leaders in and around the country who are looking for transparent options and ways to promote transparency in healthcare. And they want to do it better, basically. For the first few years, I spent time building on a pro forma, learning about costs, meeting with surgeons, and figuring out, hey, can we actually offer bundled, transparent price services to members of our community in and around Indianapolis? And we thought maybe initially we'd be able to save 10 or 15% over the current cost of care. When we finished the analysis, we realized that actually we could save between 50 and 70% from the current negotiated payouts after negotiated discounts by the insurers. And so that really kind of opened up the door to providing care across multiple demographics and people groups. We started with 4 surgical specialties, and now we're up to 30 credentialed and privileged surgeons across 10 surgical specialties providing that clinical care today. I brought with me today a document that I think kind of reflects the circumstances that we're in. This, I've kind of blacked out some things on here, but basically these are, this is actually a suit authorization form. I've been out of private practice with my previous group for about 2 years now, and there's probably about 15 names on here. Basically, a third and final request for suit authorization. Is a suit authorized? Circle yes or no. I don't remember the clinical care for those individual patients, some of which were back in 2019, and they range from $19.54 to $375. Essentially, I'm going to ruin a patient's credit score if I circle yes, and they probably won't have the option to buy a house or a car in the future over $19. And if I circle no, I don't get compensated for that clinical service at all. And so basically, I'm kind of donating my time for those individual cases. So I'm stuck in a situation where I just don't circle yes or no. I don't submit the form back. So we had to come up with a better way. So what we did is we actually bundled individual episodes of care together across outpatient surgery, from general surgery to orthopedics to GYN to pediatrics, and actually quoted that price up front, put it on the website, and said, hey, the price is the same for everyone. It came out to be, in the case of ear tubes for your infant, it's about $2,380 at our facility. The local price amongst the other health systems about $6,000. On the other end of the spectrum, with the larger procedures, total joint replacement, it's $23,500 at our facility. We've had patients travel as far away as from Nebraska because they were quoted prices of $80,000. So there's about a $50,000 savings with one surgery. It's been very interesting because the speaker just before me mentioned their employees needing access to fundamentally transparent price and value-centric care. That's most of the clients that we serve. We have actually contracts with small and medium-sized companies in and around the state that are looking for just that. And so we actually provide the price up front. It includes the entire episode of care, meaning the facility fee, the professional fees for the surgeon and anesthesia, pre-op evaluation, and post-op follow-up. So what's interesting here, and I think maybe worthwhile discussing or just at least getting the thought out there, is that when you look at the total cost of care, 90+% of that cost is a facility fee cost. That goes to the health system, the actual building or the entity that's actually providing the care. Less than 10% of that goes to all physicians involved in the care. And so I'm not really here advocating for physician payment increases, but it gives you a little bit of contextual information to kind of see where most of the dollars are actually going. So I just like to continue to work towards this front and just kind of introduce these ideas and circumstances to the committee here. What's been interesting for me is that it's been pretty bipartisan.
Mr. Panecki, we're 30 seconds over, and I want to make sure we get every witness the time available, but we'll have questions.
Okay.
Mr. Chairman, he was just getting to the point of bipartisanship. We might let him go.
We'll make sure we get in the questions.
Thank
We
you.
love bipartisanship.
Thank you for the time.
Thank you. Dr. Whaley, you're recognized.
Thank you, Chairman Smith, Ranking Member Neal, and members of the committee. Thank you for the opportunity to testify today. My name is Christopher Whaley. I'm a healthcare economist at the nonprofit, nonpartisan RAND Corporation, where I focus on price transparency and the evolving structure of healthcare markets. The information I'm going to share today draws on a variety of studies that my colleagues and I have conducted over the last several years. The United States leads the world in healthcare spending, largely due to high and variable prices. Rising spending strains government finances, as well as erodes worker wages and other benefits, particularly for lower-income Americans. Healthcare prices are opaque, fueling consolidation activity and leading to patient frustration with the current state of the U.S. healthcare system. In response, policymakers have undertaken efforts to increase price transparency. However, many of these efforts are currently incomplete. Today, I will discuss potential solutions to improve the use of price transparency data and to make this market more transparent. First, it's really important to recognize that price transparency is not a cure-all, but is critical to improve the efficiency and regulatory oversight of healthcare markets. While patients have an ethical reason to know about prices in advance, the reality is that many patients don't actually shop for care. However, my research has shown how entrepreneurs and innovators can use price transparency data to improve health insurance benefit design and create competition in healthcare markets. In addition, price transparency is critical for employers to fulfill their fiduciary obligation to provide health insurance benefits to their workforce at fair and efficient prices. An appropriate use of price transparency is not a magic wand for the healthcare system or as a way to burden patients with navigating the complexities of the U.S. healthcare system, but rather as a hub that enables other benefit design innovations and policies that will reduce healthcare spending and improve healthcare quality. As just one example, we've collected medical claims data from many employers in the state of Indiana and reported to these employers what they're paying for hospital care and prices for hospital care. Indiana employers have used this type of price transparency data to both negotiate lower prices for healthcare, to direct patients to high quality and lower price providers, such as Wellbridge Surgical Center, and to also push for policies that improve competition in healthcare markets in the state of Indiana. To allow for these types of initiatives to happen nationwide, recent federal policies seek to increase access to price transparency data through two main requirements. First, there is a requirement that hospitals must post prices for roughly 300 shoppable services, and second, insurers are required to put prices for their negotiated rates. Unfortunately, each policy has important implementation barriers that limit effectiveness. As mentioned by Chair Smith, on the hospital side, roughly 75% of hospitals are actually non-compliant with policies to post prices, with many hospitals actually not posting any data at all, or hospitals that do post posting incomplete or inaccurate data. On the insurance side, insurer-posted transparency and coverage rates have largely not been used due to file size and complexity. To improve data quality, important changes could be made. On the hospital side, penalties for not complying could actually be forced. As mentioned earlier, a total of 4 penalties have actually been assessed, despite many hospitals not complying. There are also important lessons from states. So for example, the state of Colorado recently implemented a policy where hospitals that do not comply and do not post prices aren't allowed to go after patients for medical debt. Finally, compliance with requirements could be, like many other data reporting requirements, a condition for participating in Medicare. On the insurer side, file sizes are needlessly large due to duplicate data entries and posting of prices for providers who don't actually perform services. This means that much of the data is unfortunately not accurate. Requiring insurers to limit posted prices to providers who actually perform services or include the volume of services that providers bill could be one way to actually improve the use of this data and to improve data quality. So just to wrap up, the large variation and opaque nature of prices in the U.S. healthcare system drives patient frustration with the current state of the healthcare system. Federal policies to improve price transparency, I think, are very important first steps. And just as we've seen in Indiana, I believe that building on these efforts will improve the efficiency of the U.S. healthcare system, reduce spending, and improve quality. Thank you.
Thank you, Dr. Whaley. Mr. Campine, you are recognized.
Thanks. Chairman Smith, Ranking Member Neal, members of the committee. Thank you for this opportunity to share my perspective on how transparency lowers healthcare costs for employers and consumers and promotes a more competitive healthcare system. Since our founding in 2007, Healthcare Blue Book has become one of the largest providers of cost and quality transparency solutions to self-insured employers, large state and municipal plans, and trusts. We are a large aggregator of commercial claims as well as the carrier machine-readable files, and we are a leading provider of transparency compliance solutions to third-party administrators. Through our Quantros Quality Analytic brand, we produce patient-specific outcomes on a national basis, as well as provide quality measurement solutions that are used by hospitals and other provider systems. Our job at Blue Book is to make it really easy and intuitive for members to compare providers on cost and quality. So for example, a patient can look up a joint replacement and immediately compare local in-network providers on both cost and quality. All this information is color-coded, so green is high-performing, red is low-performing. Importantly, we rank first by quality and second by cost, where quality is measured, in this instance, by patient-specific outcomes for the roughly 3,200 hospitals that do joint replacements in the United States is measured by complications, mortality, and readmissions. Lastly, the majority of our employers reinforce good consumer behavior through either shared savings incentives or lower out-of-pocket costs. In our experience, transparency works. We know that patients that shop for care are 3 times more likely to choose high-value care, and we also know that patients want this information. Over 15 years, we've seen a dramatic rise in utilization. Initial monthly utilization was in the single digits. By 2018, we were double digits. Today, it's not uncommon to see 25 to 35% or more. That's a direct result of increased patient awareness, more relevant data, so medical, pharmacy, and quality all on one platform, sophisticated analytics that enable us to better engage patients, and most importantly, alignment of benefit design and incentives with the desired outcome, which is use of high-value care. We've also observed steadily increasing patient utilization of these high-value providers. That directly puts money back into the patient's pocket through lower deductibles or lower coinsurance, or also through incentives. Similarly, over a multi-year period, our employer plan sponsors have seen their annual savings grow by 200 to 300%. Recent federal transparency initiatives have been helpful in these efforts. The hospital transparency requirements, the transparency and coverage rules, and the No Surprises Act provide a wealth of data for organizations like Blue Book. As an example, the anti-gag provisions of the No Surprises Act ensure that our employer clients have access to their own claims data. It's table stakes in terms of being able to actually understand the problem before you can do something about it. The hospital files, well, I would say imperfect, as we talked about, are still a good source of rate information, and importantly, the cash pay prices. And importantly, the network MRFs are a comprehensive source of rate and provider information, and we utilize that information to make available more services and more providers in more geographies in order to help patients shop. Collectively, I think great progress, but there are still some gaps and maybe some areas that we can improve. So I would start with pharmacy. Medications are the fastest growing cost for employers and consumers. Pricing is opaque. The pharmacy MRF requirement was removed from the transparency and coverage final set of rules, and so I would encourage legislators to consider revisiting that data requirement. The second is support for quality measurement initiatives and data. So the consumer tools really focus on price and out-of-pocket cost. I think we've established that quality is critical in order to determine value. So support for initiatives like all-payer claims databases that make more data available to third parties to do quality measurement would be helpful. I also think that there are probably some things that we can do to improve the quality of the MRF data files, both the hospital files and the carrier files. The carrier files, we're still in early days working with these files. I think with more experience, we'll get a little bit more efficient there. However, the files are large and the data values and formats lack consistency. So I encourage steps to improve standardization, uniformity, and accuracy. I'm always concerned about anti-steering and anti-tiering provisions in provider contracts. It's incredibly important for employers to be able to steer members to high-value care and to discourage use of low-value care. I think those clauses work against the interests of employers, and I think we want to preserve that ability for employers. Lastly, I think the literature is clear here, but provider consolidation results in higher prices. We certainly see this in the data. I know the committee has a hearing on this actually tomorrow, but I encourage legislators to pursue policies that foster competition in the provider market. And with that, I will conclude my remarks, but I look forward to questions.
Thank you, sir. Mr. Short, you're recognized.
Chairman Smith, Ranking Member Neal, members of the committee and staff, I extend my sincere gratitude for inviting me to testify today on the crucial topics of transparency, health savings accounts, and direct primary care as a means to make health care more affordable for the working class. It's an absolute honor to be here with you today. Inefficient payment processing is the silent killer in American health care. The U.S. healthcare system faces a significant challenge that is often overlooked, the impact of inefficient payment processing. This acts as a silent killer affecting the overall cost, quality, and accessibility of care. It is imperative that measures be taken to address these inefficiencies. We can address this problem through improved price transparency, modernizing health savings accounts, and facilitating direct primary care through direct payments can effectively tackle this challenge. By doing so, we can lower costs, enhance patient engagement, alleviate physician burnout, and attract more qualified individuals into the medical profession. Encouraging broader participation in direct payment markets ultimately leads to a more efficient and effective healthcare system in the United States. I'm William Short, Executive Chairman of Ameriflex, a prominent administrator of tax advantage healthcare accounts headquartered in Texas. Ameriflex works in partnership with Main Street businesses across the country, empowering employees to become smarter consumers of their healthcare. In addition, I proudly serve as a board member of the American Bankers Association of Health Savings Account Council. Today, I come before the committee to serve as a resource and an ally as you explore and implement critical changes to our U.S. healthcare system to better ensure affordability, accessibility, and quality healthcare for all Americans. To begin, increased transparency in healthcare pricing, coupled with modernized health tax accounts, empower patients to make informed decisions and wisely allocate their resources. Ameriflex plays an important role in this process. We collaborate with businesses, including those that serve the working class, blue-collar sectors, rural communities, as well as public sectors across the nation. Through these partnerships, we enable employees to take full advantage of tax advantage healthcare accounts, granting them greater control over their healthcare expenditures. According to the Devenir Research 2020 survey, a significant majority of households, over 78%, who have HSAs as part of their healthcare coverage, make less than $100,000 per year. Allow me to take a moment to share a story about how direct payments can work in an employee benefit plan. One of our partner businesses, A1 Locksmith, based in Dallas, Texas, had an employee who was able to take advantage of the direct primary care arrangement. And through a wellness visit that had allowed for him, with his primary care physician, to uncover that he was a type 2 diabetic. Through this arrangement, they developed a treatment plan that allowed for him to hopefully avoid serious medical conditions that could have resulted from the untreated diabetes. In addition to our first-hand experience with employees, the Society of Actuaries commissioned Milliman, which found in May 2020 report entitled Direct Primary Care Evaluating a New Model of Healthcare Delivery and Financing, that savings of 20% could be achieved by employers who had decided to install a direct primary care arrangement in their health plan. In addition, our customers highly value HSAs as they provide individuals with a tax-advantaged means to save for medical expenses and encourage individuals to become proactive healthcare consumers, all translate to active participation and improved individual health outcomes. However, the effectiveness of HSAs can be hindered by an opaque healthcare system. Without transparency and pricing, quality, patients face significant challenges in making informed decisions. It is imperative that we collectively address this issue to unlock the full potential of HSAs and empower patients to become wise health consumers. While HSAs have demonstrated numerous benefits, there are still barriers that need to be overcome. Currently, working Medicare, TRICARE, Indian Health Services, and Medicaid beneficiaries are excluded from utilizing HSAs, limiting their ability to save for future health medical expenses. This discrepancy must be rectified, ensuring that all individuals, regardless of their health care coverage, can pay for their out-of-pocket costs with tax-advantaged health care accounts. In addition, special consideration should be given to low-income Americans by spending HSA accounts, seeding HSA accounts in Medicaid could greatly assist the working class in covering their out-of-pocket expenses. Furthermore, out-of-date regulations obstruct the adoption of innovative healthcare delivery options for patients and employers, as current HDHP compliance barriers limit the integration of DPC arrangements with HSAs. Addressing these compliance challenges would enable more individuals to benefit from the advantages of DPC while utilizing health HSAs effectively. In conclusion, transparency, health savings accounts, direct primary care hold tremendous potential to make healthcare more affordable for the working class. By increasing price transparency and modernizing regulations governing HSAs, as well as overcoming compliance challenges related to DPC, direct primary care, we will create a more effective, inclusive, and affordable healthcare system. Thank you once again for the opportunity to share these views with the committee.
Thank you, sir. Dr. Gil Finnan.
Sorry. How's that? My name is Rick Gilfillan. I'm a family physician and currently in independent consulting doing mostly volunteer work. In addition to practicing medicine, my prior positions include CEO of Trinity Health, a large national nonprofit health system, the Deputy Administrator and Director of CMMI at CMS, CEO of Geisinger Health System, Senior Vice President for Contracting at Coventry Health, and Chief Medical Officer of Independence Blue Cross. My comments today are strictly my own. I believe we should be as transparent as possible about the quality and cost of healthcare. But I don't believe today's operative assumption that if we give patients pricing information, they will respond as logical economic actors in a well-functioning marketplace, thereby lowering costs and improving outcomes. It seems quite ironic and inappropriate to me that given America's broken healthcare marketplace, where most businesses operate outside of usual marketplace constraints, we want patients to provide market discipline by shopping. Meanwhile, insurers with near monopolies take 17% of the cost of care for operations and profits. Medicare Advantage plans with near monopolies receive subsidies at $1 trillion over the next 8 years. For-profit hospitals and surgical centers cherry-pick profitable communities and patients and services, leaving lower-income communities to nonprofits. Drug companies with 17-year monopolies keep the price of insulin so high that patients ration it for themselves. And by the way, congratulations on passing the No Surprise Act and the Inflation Reduction Act to allow negotiation of drug prices. But there remain powerful drivers of cost in the system. And against all that, we ask mostly lower-income patients, when they are sick and vulnerable, to find the best price for services they desperately need. Have any of us actually done that? I haven't. In my written testimony, I provided 5 conclusions. 1, despite the dedication and skill of our healthcare workforce, our system, compared to similar countries, is less effective, less efficient, and fraught with inequities. We spend twice as much, $6,000 per person versus $12,000. In 2019, our life expectancy was 3 to 4 years less than these other countries. Post-COVID, our life expectancy actually decreased 3 years, and for Black Americans, life expectancy is 5 years less than for white Americans. Over the past 40 years, we have built a financial and administrative structure on top of the actual delivery of healthcare. This financialization has created a complex healthcare system that seems more driven by the pursuit of wealth for institutions than health for populations. Employer-based insurance results in high service prices and commercial costs and shifts resources from low-income to high-income communities, perpetuating inequitable and segregated health care. Despite the ACA's great improvement in coverage, increased cost sharing, and high deductibles expose families to higher prices, causing care avoidance, family medical debt, and bankruptcies. And studies show that high deductibles decrease costs marginally, but due to patients avoiding care, not due to shopping. HSAs have been shown to not encourage shopping, but to serve more as planning tools for taxes for high-income individuals and families. I offer the following principles for your consideration. 1, ensure comprehensive health insurance to cover everyone in America. 2, eliminate overpayments in government programs like Medicare Advantage. 3, create an all-payer system with standard pricing for all populations. 4, create a public option built on a network of strengthened primary care and accountable providers. 5, maintain current levels of employee contributions. 6, use savings resulting and redistribute other spending to address the social determinants of health. And 7, continue publicizing cost and quality data. Across America, in each of your districts, some for over 150 years, nonprofit health providers have been a lifeline. Their dedicated staff are available 24/7 to anyone who needs them, unlike for-profit institutions who limit their care to high-paying individuals with the wealth or commercial insurance to afford it. Nonprofits remain committed to their founders' values and missions to serve. Yet, nonprofit healthcare is often portrayed as the problem here in Washington. We should address the concerns that you all raise about that, but as we work to improve healthcare, I believe we should support these organizations so that they can continue to be that vital lifeline in your communities. Thank you very much. I look forward to answering any questions.
I want to thank you all for your testimony. We'll now proceed to the question and answer session, and I will first begin. Dr. Whaley, in my opening statement, I referenced analysis citing less than 25% of hospitals are currently complying with the price transparency rules, and you noted that as well in your testimony. In your research, what response have you seen from hospitals complying, or more likely not complying with the price transparency rules and regulations we already have in place?
Thank you, Chairman Smith. As I noted in my opening testimony, there have been audits of price transparency postings that have noted that roughly 25% of hospitals are actually compliant, meaning that 75-ish% of hospitals are actually not complying with these requirements. As I also noted in my opening testimony, I think there are important federal actions that could be done to improve compliance.
Mr. Short, we have armed Americans with patient-first health accounts such as HSAs, and then told them to go out into a world where they struggle to find out what their care will actually cost. That's a little like giving a gift card to someone and sending them to a store with no price tags on the clothing. Given your work on HSAs in particular, how will more price transparency enhance the benefits of such health savings accounts?
And speaking for over the 1 million American families that Ameriflex has helped, efficiently spend their health care dollars to get the care that they need, the 30 million HSA accounts that are currently in market, and the additional 35 million tax advantage accounts, FSAs and HRAs, by opening up more price transparency options, we can make them more powerful consumers in terms of looking for care and being able to get the care that they need at an efficient price below the deductibles beyond items that wouldn't be covered by catastrophic insurance.
Ms. Troiano, price transparency is critical not just because patients have a right to know, but also because it disrupts the regular payment and insurance models, encouraging competition and therefore lowering cost. How have you seen price transparency lower cost for your small business and its employees?
It has lowered first of all, let me make it clear that our premiums did not lower this year. Our premiums were, originally came back at 35%. With sidecar, they were 10% higher, so our premiums did not lower. 10% was the palatable amount that we could take in, 35% was not, and there were several companies that refused to even bid on our business because we are small and we had big claims. So the savings that we're seeing is for our employees, which was more important to us than making sure that our savings were there. And what we're seeing is a person whose spouse had back fusion surgery that would have been $160,000 and ended up being about $80,000. We see our employees are able to go to any pharmacy, so they can use Mark Cuban's Cost Plus Pharmacy. They're saving a lot of money through that. Single Care, which is an app, GoodRx, which is an app, and they do not have that money. They're not outputting money up front. Sidecar puts the money out up front, and all the prescriptions are paid for.
Dr. Pinecki, you run an outpatient surgery center that has employed transparent upfront pricing for patients. How have your patients reacted to confidently knowing the price they will pay for their procedure?
It's been super encouraging for me. One of the reasons why I did it, and probably what fuels me moving forward, I understood that employers were actively pursuing value, quality, and price, defining value as quality and price in their care for their employees. So I knew that was going to be a likely participant for our business. But what's been really interesting is there's been folks that have actually been shopping for care. So they've actually been online. We actually receive a fair number of patients. I mentioned the patient from Nebraska. We've had a patient travel from the Upper Peninsula of Michigan for colonoscopy. That's a relatively low-price procedure compared to a joint replacement or some of these larger surgeries we do. And so the feedback that I get from them has been super encouraging. They said, hey, I've looked around, I've called around, the hospital was this price. We called the neighboring city, the hospital's that price. We're willing to travel 10 hours to come here to receive a bundled price that we knew was exactly what the cost is going to be. There's no balance billing or a la carte billing outside of that. So it's been super encouraging.
Mr. Campine, as we look at the price transparency rules for hospitals and health insurers, we need to ensure that the public data is actually usable for patients. Given your experience running Healthcare Blue Book, what are the current rules limitations, and how can we enhance the usability of pricing information for the individual patient?
Sure, I'll start on the hospital side first. First of all, we need compliance, right? And second is the files, when you've seen one, so we need some standardization in terms of the values that are in those files. On the hospital side, it's 300 services. Reasonable coverage, only 70 of which, if I'm remembering correctly, are standardized and required. And you're looking, in most instances, at the facility piece of the charge, right? So we don't know what the anesthesia is necessarily, or the doctor, if the doctor is not affiliated with the hospital. So it's really helpful, right? When we think about consumers and how we present prices, it's in the context of an encounter. Everything you need to know about the cost of that service for the day that you go in. This is what is so great about the surgery center and the bundled pricing. You know these things. Secondly, so much care is moving into the outpatient environment. Generally speaking, right, the HOPD, or the hospital outpatient department, is the most costly alternative in terms of site of care for something like an ACL repair. So today you only look and can compare, let's say, for example, across the lowest cost among the most expensive provider type. So you really need to have all of that information. What do the independent ASCs charge? What is their price? What is the total price with everything combined? How do you compare that with the hospital? So I think those are some of the ways that one can improve that data and make it more usable. Of course, that's our job, right, at Blue Book, is to do things like that, but those are some of the gaps. We're a little bit earlier, right, on these carrier files. As Chris had alluded, these are enormous files. We'll get better at it. We like these problems. But we already know that the data, the file formats, again, when you've seen one. So it takes a ton of time to load them, clean them. There are what we generally refer to as zombie codes in this, where every provider is given a price despite the fact that those providers may not actually perform that service. That's not helpful to anybody. And importantly, there needs to be some sort of check. We sit in sort of a unique position in that we are a large aggregator of claims data. Adjudicated medical claims data, think of as an itemized receipt. You know what was actually paid according to that contract on those services, and you can compare it to what is being reported in the rate files. The rate files are just the contract files. Remember, rates have to be run through an adjudication system before you know what the receipt looks like. Again, early stages there, but I think we'll probably get better and better at aligning those two.
Thank you. I now recognize the ranking member, Mr. Neal, for any questions.
Thank you, Mr. Chairman. I want to thank our witnesses again and to remind all that Democrats have pushed for health care improvements from the bottom up, focusing on those who need the greatest supports, working to fill the coverage gap, making marketplace coverage more affordable, and lowering drug costs. We want the other side to help in these achievements and to continue to look at consumer-focused gains that Democrats have achieved, and their health platform appears to be all the time on the other side for the healthy and oftentimes for the wealthy. Consumer shopping and tax cuts for the well-off through health savings accounts alone won't do it. Dr. Gilfillan, we've heard from a number of our colleagues that price transparency in consumer shopping is the cure-all for the nation's healthcare challenges. This approach is unlikely to yield large price reductions for consumers and seems to have significant downside for those very consumers, forcing them to shoulder more responsibility as they shop for better health care services. Aren't these proposals more of the same, leaving consumers unprotected, sticking them with high bills, and then, of course, more tax cuts for the well-off through HSAs? Dr. Gilfillan, one of my concerns with that notion has been that HSAs are going to revolutionize health care when most consumers don't have enough money in their bank accounts to contribute to one. And the average value of the HSAs really doesn't pay for all that much. We know that unpaid medical bills are one of the largest sources of consumer debt. Doesn't this approach just risk shifting more cost onto consumers? Dr. Gilfillan, from your perspective, having worked with providers and insurers, it's important that we hear your contribution this morning. I want to acknowledge something as well in the Trinity Healthcare system. I've been a longtime friend and champion of the Sisters of Providence. Long before the law required that people be cared for at the entrance of a doctor or a hospital, the Sisters of Providence knew that mission statement. They were running healthcare systems, they were running school systems across America, and our lives are much improved because of what they did. They, as you know, administer the Mercy Healthcare System, which is part of the Trinity Healthcare family, and they have always played a critical role in making sure that the poor were treated and that disadvantaged patients would not be those who were left only to profitable institutions for the decision as to whether or not they would get health care. So I ask you, as you've done in your testimony, to discuss some of the proposals that we're hearing today that might well exacerbate inequities that are already present in our healthcare system. I think that many of these proposals could worsen the delivery of health care, tilting again in favor of those who are indeed healthy and wealthy. So let me give you some time to talk about those issues.
Thank you, Ranking Member Neal, and I share your admiration for the Sisters of Providence and the many congregations that formed healthcare systems in needy communities across America, and other voluntary organizations who have done that and have been the backbone of the healthcare system in America. And I note one of the major aspects of the financialization of healthcare in America has been the fragmenting of care, the cherry-picking of care, the creating organizations, services, both financial and delivery, intended to profit from taking those segments where there's the most money, the most opportunity to make more money, and then taking those profits and paying them out as dividends to shareholders or stock repurchases to increase executive compensation, taking money out of the healthcare system while nonprofits continually reinvest in healthcare. So I think that is central, and I think the specific stories we hear frequently are actually telling anecdotal stories about small instances of shopping behavior. Large-based studies have shown HSAs do not increase shopping activity. Large studies have shown that deductibles, cost sharing, lead to people avoiding both needed care and perhaps unnecessary care, both. That's where cost savings come from. Once again, we're trying to solve the problems of a commercialized, financialized healthcare system on the backs of people who can least afford it.
Thank you, and I want to wish a special shout out today to Sister Mary Caritas, who at 100 years old is still helping to run Mercy Healthcare System, and also former president of the Sisters of Providence. Thank you.
Indeed, and a noting of her remarkable constituency, but also the great healthcare that actually has gotten so much better in America over these past 40 years. We just need to create a healthcare financing and administrative system that allows our great professionals to be their very best.
Thank you, Mr. Chairman.
Thank you, Mr. Neal. Mr. Buchanan is recognized.
Thank you, Mr. Chairman, and I want to thank all of our witnesses. The reality is, this year, healthcare will be about $4.3 trillion. When you look down the road, Medicare is going broke in a matter of 3 or 4 or 5, 6 years. So what we've got's not working. Is somebody that's been in business 30 years before I got here. We paid for all our employees the first 20 years, no deductibles, nothing. What's happened in the last 10 years is the train's got off the track. I mean, there's a very high percentage that's getting pushed now, not just higher premiums to the company, but to the employees. So I'm talking about startup companies, small businesses, medium-sized businesses. It's a big number, and a lot of them can't even afford the insurance. But I can tell you in the real world, the companies used to pay it all, but now maybe they're paying $700 or $800, and the family of four is paying another $600, $700 out of pocket. And these are a lot of blue-collar workers. So that's the reality. That's where we're at. So the idea to think that we just keep doing the same is insane. We need to find a way. This is one way, is transparency and competition. It works everywhere else. It needs to work here. It needs to be somewhat applicable, because a lot of these companies are paying 20% average a year for the last 5 to 10 years, and that's the reality in Florida. Ms. Troiano, what do you, just out of curiosity, in terms of your employees, what percentage do you pay? What gets passed to them, or do you pay at all?
We do pay. The company pays the majority. We pay about 86% of the premium, and the rest of it, that's on average. We keep our single coverage at $153 for our employees to make it affordable.
What about a family, if they've got a family of four?
Family coverage has gone from, prior to 2012, it was $50 a month. It's $450 a month.
So what does the employee pay?
The employee pays $450.
Okay, so that's my point.
Yes.
That's something that doesn't get talked about, but they shouldn't be paying anything, or ideally, or a minimal amount. $450 a month when you're living paycheck to paycheck, that's the harsh reality. And you've got 100 employees, it's not like you've got 10.
Correct.
So, and by the way, you got a tough job as HR, it's not the easiest job. Mr. Panecki, talk a little bit more about, you mentioned about the percentage was 35%, or what was the percentage you were talking about? What you're seeing, a 70% reduction or increase or something, you threw a big number out there. I'm very excited about better understanding what you're doing, how you're doing it, because I think some level of competition does make a difference in transparency. I know personally people that shop, take their time, buy a house, buy a car, all the things we're talking about. They're going to get much more of a better deal, ideally. This doesn't work for everybody, but it'll work for a lot of folks. Without competition, it's a monopoly. So let's call it what it is. So what's your thoughts on what you're seeing for small, medium businesses? What's the reality that you're finding? How much are the employees paying? How much are the employers paying? And what's that increase over the last 5 or 10 years?
Yeah, that's everything I've heard so far from the last couple of testimonies is spot on, and what you mentioned is also correct. In the state of Indiana, once you reach about 100 employees, it becomes cost advantageous to be self-funded, self-insured. So then individual companies, greater than about 100 employees are paying the cost of those claims. And so it's not just, a small percentage of businesses. In Indiana, it's about 70% of those businesses are basically footing the bill, in addition to the premiums that are being paid by the employees.
So what's the employees paying? Because that's, to me, there's 100 million employees out there that are having to chip in a lot more than they ever imagined before, and that's why they're living paycheck to paycheck.
What I've seen is at least 25%, with the employers being roughly 75%, but in certain circumstances, it's even more than that.
And then what are you just seeing in terms of reduction with what you're doing? Take a minute to talk a little bit more about competition and transparency, the difference it's making in premiums.
When we were building the prices for the delivery of care based upon the CPT codes, like if you need your gallbladder taken out, there's a CPT code associated with that. We knew what Medicare was paying for that, and we had some commercial insurance data. And so the question was, could we actually save significant amounts? You know, and honestly, I thought maybe we could find 10, 15% savings. That number that I mentioned earlier, that 50% savings, the payout from a commercial insurer for, you know, a lap chole, which is a gallbladder removal, in our state is somewhere around $20,000 after negotiated discounts.
So across the board, 50% or something?
We're doing it for 9.
Do you have any interest in
So
coming to
probably
Florida
about
to set up
60,
business down there?
65%.
I yield back, thank you.
Mr. Doggett is recognized.
Thank you, Mr. Chairman, and thanks to our witnesses. As a long-term advocate myself for greater openness, for greater transparency, I certainly support having better and more extensive data concerning healthcare prices. Comparative price data can be helpful to us as policymakers and can help identify inefficiencies in cost and quality. What transparency cannot do is to fix our broken healthcare system that is riddled with anti-competitive behaviors, increasing consolidation, and government-approved monopolies. It's not like shopping for a car or a television. There's very little competition among healthcare services, and monopolies drive up prices. Even if a consumer has complete pricing information, understands every option, and has time to shop for the best deal, healthcare prices are still astronomical in a broken market. And unlike shopping for a television, healthcare is often an emergency item, an accident, a heart attack. There's not a chance to do much shopping, nor is the lowest price the biggest consideration at that dangerous point in someone's life. For more than a decade, the Republicans have had as their principal healthcare goal repealing Obamacare and replacing it with nothing care. Now they claim that if we have enough price information and we have these health savings accounts, we have a panacea. Well, I don't believe that that's true. I think that health savings accounts, not unlike the junk insurance plans they've also promoted, have some serious limitations and are often very skimpy. For example, there's data that shows that the majority of U.S. households have less than $3,000 in their checking and savings accounts. But the average deductible for an HSA qualified plan is about $2,500. So for many families who have an HSA, an emergency can still wipe out a family savings. And I think it's rather misleading to talk about 78% of families, people in families being covered by HSAs. Because the data that is really significant is how many people have money within an HSA. And if you look at the 2020 data, there are only 2 million people in America who claimed a deduction for a contribution to an HSA. It may just simply mean that 78% have employers that offer them little else than a high deductible plan. Having an account doesn't mean you have much or any money in it or even a dime in it. In fact, the truth about HSAs is that they're a boon for those at the top of the economic ladder. Only 5% of Americans earning less than $100,000 actually had money in an HSA. Under the guise of affordability, HSAs are really a triple tax advantage for the wealthy. They provide tax-deductible contributions, earnings are tax-deductible, and withdrawals are also not taxed. It's a great contrast with the flexible savings accounts that many people rely on, where you're called upon to guess how much your health expenditures will be the next year, and if you guess too high, you lose those dollars. No, in this case, this is a lucrative tax shelter that grows year by year. We need to recognize that health savings accounts are an expenditure to the people of America. They're a tax expenditure that is as real as if we went down and asked the Appropriations Committee to approve the almost $200 billion that will be spent over the next 10 years on health savings accounts, even if there are no changes made in them. Republicans are really big spenders when it comes to these tax loopholes, and that's what we have here. I think, Dr. Gilfillan, one comment I'd ask you about is your reference to Medicare Advantage. How much is the overpaying for Medicare Advantage denying us an opportunity to improve Medicare and other health care programs?
Thank you for that question, Congressman Doggett. This year, estimates are between $25 and $50 million in $1 billion in overpayments to MA plans. That is projected to total almost $600 billion just from the risk score gaming we know they do to make their populations look sicker over the next 8 years. And all subsidies combined look like about $1 trillion in subsidization over the next 8 years. That's more than enough to address the issues of housing insecurity and food insecurity that we know contribute significantly to discrepancies and inequities in life expectancy in America.
Thank you very much. Mr. Chairman, I would ask unanimous consent to include in the record a report from the Center on Budget regarding health savings accounts and their limitations.
Without objection. Mr. Smith, you're recognized.
Thank you, Mr. Chairman. Thank you to our witnesses. And hearing the comments moments ago, I'm tempted to spend my time countering so many of those things. Let me just say that I hope that we can work together to empower patients. Empower patients to make the decisions, whether it's on a procedure or whether it's on the financing, that we can acknowledge that way too often patients do not have the opportunity to make decisions for themselves. And I don't think it should be that the government should make decisions for them. Lots of evidence that that hasn't worked. But I do believe that today's hearing is an opportunity. Certainly reminds me, as was discussed earlier, about the work, the bipartisan work that we did on medical billing, surprise medical billing. And I believe that price transparency rules aim to address a similar underlying problem, and that is consumers face too much uncertainty and lack information about the cost of their care. Just like with surprise billing, our goal should be helping patients avoid unnecessary, unexpected costs. The ability to compare and factor costs into decision-making can also help patients be better informed healthcare consumers. In order for our healthcare system to be as efficient as possible and for our constituents to stretch their healthcare dollars, people need access to accurate, accessible information to make logical, direct cost comparisons when shopping for care. There are many upsides to providing patients the ability to shop for the care that best meets their needs. Providing a clear explanation of their liability gives people the knowledge and power to save in advance or better budget for a procedure they know they will need. This knowledge, along with planning and increased flexibility, can help people avoid large and problematic medical bills. Part of this planning and increased flexibility should include more discussion around whether or not to choose a health care plan that includes an HSA, and examining how we on this committee can empower patients with tools to make those HSA dollars go further. As you know, HSAs allow beneficiaries to save tax advantage contributions for further health care needs. I've worked to increase the flexibility and value of HSAs for years. For example, earlier this Congress, I reintroduced the Home Care for Seniors Act. This would allow HSA reimbursement for qualified home care expenses. I was also pleased to introduce legislation with Congresswoman Steele, the Telehealth Expansion Act, which would permanently allow for first dollar coverage of telehealth in the high deductible health plans, which legally must be paired with an HSA. Mr. Short, in addition to the two pieces of legislation I just mentioned, would you say there are any actions Congress should take to help patients more effectively utilize HSAs and become more empowered healthcare consumers?
Absolutely. Any way that we can allow for HSA dollars to pay for more direct payment options like direct primary care is paramount in terms of addressing this inefficient payment process that we're now faced. We have a constant confusion when it comes to health insurance and health care. Health insurance is not health care, and so it does not matter which grouping provides the catastrophic insurance. If we don't address the underlying payment issue, we're not going to solve the problem. So coupling that with price transparency and allowing for direct payment options and removing these constraints on HSAs tied to high-deductible health plans will open that up and expand HSAs and health care for everybody.
Thank you. I think it's really important that we focus on policies, as has been mentioned, as you mentioned, that actually bend the cost curve. And more consumer involvement, more consumerism is the best way to do that. And I think that disregarding realities in Medicare Advantage and other very directly consumer-oriented decisions, dismissing those realities is not doing the general public a service. I'm very concerned about that moving forward, and we need to do things and pursue policies that, like I said, bend that cost curve rather than just shifting around who pays for what. You know, the high deductible in the individual market now isn't as offensive as apparently it was for say, the high-risk pool before Obamacare. So I hope that we can pursue bipartisan solutions here. I represent a great number of critical access hospitals which reflect the needs of the community. I appreciate the opportunity to engage with them, to hear their concerns and empower them to help their patients as well. So again, I appreciate this opportunity. It's timely, it's important, and I hope that we can work together to empower patients across America. Thank you. I yield back.
Mr. Thompson is recognized.
Thank you, Mr. Chairman, and thank you to the witnesses for being here today. I'm all for transparency, and I think it should include clarity in billing as well. It's incredibly unfair that when it comes to health care, and perhaps only health care, Americans almost never know what something costs before we buy it, or how to figure out the bill after we've received the services. Health care is not like buying a car, a refrigerator, or a bicycle. If you need health care and you need it urgently, you don't go shopping or log on to Amazon. You go to the nearest hospital. If you need a transplant, you can't decide to wait a few months to see if kidney prices come down. If you're injured in an auto accident, you're transported to a hospital, not to your house, so you can go online to shop for the best deal or the cheapest deal for broken bones. So I appreciate the chairman holding this hearing, and I hope it's a prelude to bipartisan efforts that will bring costs down. As mentioned, so far all we've heard are years and years and years of bemoaning the Affordable Care Act and trying to discredit that. We should be, and we should have been, working together to deal with the underlying issue. Dr. Gilfian, I'd like to ask about the enormous administrative superstructure you talked about and the let people shop around approach some of the witnesses have mentioned today. I'm all for empowering patients, but I'm concerned that everyday folks will have a tough time navigating what we all agree is absurdly complicated administrative financial system. Can you talk a little bit more about that? And do we have evidence that consumers are really shopping around?
Certainly, Representative Thompson. The superstructure I mentioned has grown over the last 40 years after managed care was introduced, and through several iterations, changes. We've seen it actually grow to the point of between hospitals, physicians, and insurance companies, it's probably consuming somewhere around 25% of the total we spend for healthcare. And it's making healthcare harder to get, and it's distorting the actual delivery of care. In my mind, the way to deal with the cost problem is to get at the root cause of that. And I believe one of the root causes is actually the employer-sponsored health insurance marketplace. HR departments want everybody in their network. And when you do that, you create the reality of must-have providers. Providers you have to have offered if you're offering an insurance plan. Those must-have providers have the ability to just about dictate price to insurers. That's what leads to the high costs, and they're real, that we see in healthcare.
Thank you, Doctor. Well, but I want to make sure we have time because I have another question. I want to talk about hospital reimbursements. You pointed out the huge range of profit margins in the world of hospitals. I'm concerned in particular that while some hospitals may cherry pick profitable parts of the market, other hospitals, particularly rural hospitals, are constantly fighting just to stay open. Can you talk about the impact an across-the-board hospital payment cut would have? Are all hospitals in the same situation?
No, they're very different, as you point out. And of course, critical access in rural hospitals and safety net institutions are in the most precarious positions. They receive most of their funding through Medicare and Medicaid. The rates are lower. They have no market power frequently to negotiate high prices on the commercial side. And as a result, they're constantly on the edge of financial ruin. I believe that we need to move to a different way to reimburse hospitals, that we should have common pricing, as we do for Medicare, as we do for Medicaid, as is used by Medicare Advantage plans. Administrative pricing that is set reasonably, that enables all hospitals in all communities, serving all populations, to receive adequate reimbursement and be successful.
And how can we help consumers navigate this very confusing billing system that we have to deal with whenever we receive services from a hospital?
I believe we have approaches like bundle payment, where indeed you put all the costs together, are helpful. But at the end of the day, I believe fundamental change in the way we reimburse hospitals and the elimination, frankly, of front-end deductibles and high cost sharing for patients is the way to make patients, give patients the opportunity to be thinking about what they need to do for their health, not what they need to do to avoid bankruptcy.
Thank you very much. I yield back.
Mr. Kelly is recognized.
Thank you, Mr. Chairman. Thank you all for being here. Every time we have one of these get-togethers, I'm so thankful that you take a day out of your life to come and talk to us. And we give you 5 minutes to tell your whole life story. And then we tell you what our stump speech is when it comes to these things. Ms. Troiano, so I'm an automobile dealer. One of the things we do, because we believe our team is so valuable, is to provide health care and pension plans for them. Now, people say, you only do that for your own good. I said, yeah, you know what? When they're working and they're productive, they're profitable. When they're not, if they're hurt or sick, they're not. It's just a simple business plan, and I know that we like to confuse what we're doing. I don't know how in the hell an outfit that's $33 trillion in the red can tell you guys how to run health care. It's just amazing to me about we sit here and we babble about. I have 52 people of our team. We're paying almost $600,000 a year for that health care coverage. Now, where does that cost go? It goes on the cost of every product we sell, every service we sell. We are in a very competitive business. And you know what it's like. Talent is so hard to find today. Keeping talent healthy is so expensive today. So I listened to everything that you've all said, and honestly, I don't know if anybody has the right answer. This isn't a Republican versus Democrat, Democrat versus Republican, where we don't care about people getting sick or ill or dying. That's crazy. That's political speech. It has nothing to do with the health of this country. So I thank you all for being here, but I got to tell you, this is mesmerizing to me because I actually pay for this stuff every month. I just recently had a medical incident. I have no idea what the cost of it was, by the way. Now, I wasn't in a position to bargain with anybody, so that's, I'm in the automobile business, and usually people come into our store. They say, we're going to 6 different stores. Tell me what the best price is on this half-ton pickup, and if you're the lowest price, I'll come back and get it from you. I don't think you can do that if you have some kind of a trauma experience and you're not able to go out and compare pricing. So I don't really know what the answer is. I know it's a good topic for us to talk about. Do any of you have any idea of how we could solve this problem? I don't want to attack HSAs, by the way, okay? Let's just leave that out. Tell me what we could do. And I know listen, we're down to 2.5 minutes. That's because I've been running at the mouth. Just, if you can, each of you can weigh in. If you could wake up tomorrow to a health care plan that made sense, what would it be? Ms. Troyan, why don't you start, because I know you go through this every day.
I do go through it every day, and I appreciate the question. The fact of the matter is, transparency would help. It would help tremendously, because we are teaching and training our employees to go out and look for health care, look for the best health care they can get, and look at the prices. If I want to say what health care should be, it should be like it was 45 years ago when I had my son. When I went to the doctor, I paid my doctor $25 a visit or $20 a visit, and I had major medical coverage. So when I went into the hospital and had him, and it was $263 for 5 days and a blood transfusion, I've still got the bill. It was covered by my medical insurance. Other than that, lab work was a few bucks here and there. I covered that. I paid for that out of pocket. Then HMOs came along, and everybody felt that they should only have to pay $10 to go to the doctor, and it doesn't work that way. And now we're into high deductible plans. What we have found through Sidecar Health is that they're able to go in and they're able to find the doctors, they find the prices, and our employees are able to shop for that care. And then they come in and they may talk to me about it, they may talk to the owner of the company about it. But protecting the employees and protecting their wallets is so important nowadays because everything costs so much.
Yeah, listen, we're going to run out of time, but I'm just going to share one story with you because I know you've been through the same thing. So a new person comes on board, new hire, and you said, hey, listen, these are the benefits that we offer. We have health care and we have a pension. We'd like to see you sign up for our health care plan. I say, you know what, I don't really need a health care plan. I'm young and everything's fine, I don't have to worry about it. Eventually, they'll come in and say, listen, can I still get on the health care program? And I said, well, I know you got married about a year ago. When's the wife due? That's when they want to do it. They want to get coverage after they've already experienced what it is they need to cover. Listen, I'm out of time. You guys are incredible to come here and spend your day with us. Please, keep giving us the information we need to have. Everybody needs to weigh in. So thank you so much. Chairman, thanks for having this hearing. I think it's good for everybody to hear what it is that we're challenged with. Thank you.
Thank you, Representative. Mr. Larson is recognized.
Yes, thank you, Mr. Chairman, and want to associate myself with the remarks of Chairman Neal. With this exception, I'd like to throw in the Sisters of Notre Dame as well for the work that they have done tirelessly. And yeah, I hope there's a direct path to heaven for me, Mike, on that. So, and also Mr. Thompson's comments. And Mr. Gilfillan, I wanted to ask you, in your 7 principles, and I believe you were in the process of answering Mr. Thompson's question, you indicate in one of your principles, create an all-payer payment system using administrative pricing. Could you elaborate on that, et cetera, what you mean by that? And how would that impact everyone's concern that there be transparency, and how will that better help the healthcare system overall?
Certainly. By administrative pricing, I mean prices that are established by administrative edict, if you will, as we do with Medicare and Medicaid. And the largest privatized health insurance program in America, Medicare Advantage, actually uses administrative pricing from Medicare, and it's the only reason it's successful. So, but the proposal is, rather than allow the marketplace to establish rates for paying hospitals, which is what we have experienced for the last 40 years, the result of that is extraordinarily high prices because employers insist on having certain hospitals in their networks. That just has driven up prices. The marketplace is broken. It's not like shopping for cars. Every patient's needs are different. They occur as emergencies. They're unforeseen. The vast majority of dollars as one gets older are not related to shoppable services, but to acute events. And the reality is that's what's exposing people to these high prices. So I believe establishing a set of prices that are the same, whether you're a safety net provider or a provider in Bryn Mawr, Pennsylvania, in a high-income community, We should not differentiate how much we pay hospitals. We should, as we do in Medicare, we should just pay them according to a set fee structure. In doing that, we will significantly decrease the exposure that people have to these high prices. And finally, as I said, I would eliminate deductibles because they're actually causing people to avoid care. And differentially, poor people, lower income people are actively avoiding care, and well-to-do people, the limited number, only 17% of all Americans have an HSA, the very limited number of people that do are paying for it through their tax-exempt spending accounts. So once again, we are asking low-income folks to shoulder the burden of shopping and going out, even when they are sick and vulnerable, to get complicated services that, as Congressman Kelly points out so clearly, oftentimes are emergencies.
You also said that you would continue transparency efforts to collect information on costs and outcomes, which seems to be universally agreed to with everyone on the respective panel, and outcomes of care utilizing tools like patient-reported outcome measures. What are PROMs? Could you?
Yes, it's simply calling you and asking you after you've received a service, how are you doing? Not just were you satisfied, how are you doing physically? Are you better as a result of your hip surgery? Are you walking more? How fast did you recover? Those are patient-reported outcome measures. We don't do much of that, unfortunately. We tend to rely on very narrow metrics that allow people to perform to the test, basically, as opposed to whether or not our patients' experience and outcomes are what they expected. So that's what PROMs are.
Keeping in mind also the issue of transparency, I do think, Mr. Chairman, that we have to be transparent that why we're having this hearing, and while I'm sure many Americans across the country are tuned in, what they're concerned about most is the fact that we are about to default on the dollar. And we have a responsibility in this committee to deal with the debt ceiling. And we have millions of fellow Americans, 66 million Social Security recipients, concerned and wondering whether or not they're going to get their check. That's what we should be focused on. I yield back.
Mr. Larson, there's only one chamber that has increased the debt limit. It was the House Republicans. Not one Democrat voted to increase the debt limit under the Limit, Save, Grow Act. We're waiting on the U.S. Senate to actually respond, or the White House. So hopefully they do not want to default. Would love to recognize Mr. Schweikert.
Sorry about that, Mr. Chairman. We're trying to do some math in the background on the fly. And this is for my brothers and sisters here on the committee. I think actually one of the things that always frustrates me is we sort of are mixing, is the colloquialism, oranges and apples. When you talk about the ACA was a financing bill. The Republican alternative was a financing bill. It was who got subsidized, who had to pay. And somehow we take joy saying we did this for people because we handed out more subsidies. I wish the committee would actually engage in something a little more intellectually robust and actually a discussion of not how we subsidize, but what we pay, not who pays it. And that's actually where some of this conversation could be actually much more robust and a lot more mathematically honest. Mr. Whaley, or Dr. Whaley, and forgive me if I mispronounced your name. I've been trying to dig through some of the RAND studies and those things. So I want to walk through first some concepts because you have one chart in here that sort of talks about, let's refer to it as subsidized cross-subsidization, transfer pricing. Private markets functionally subsidizing are dramatically more expensive than government paid-for markets. So I have a Medicaid, Medicare population, sometimes my Indian health care services, my VA. But when I look at this chart, I mean, you have some here that the private pay market, 300% higher?
That's correct.
And is that some functionally, is that greed or is that a undercompensation from the government market into those populations?
That's actually one of the things we looked at and noted in my statement, is that variation is actually not tied to the share of patients that a hospital has that are, say, Medicare or Medicaid. The large difference in prices that we see illustrated in that chart really reflect differences in negotiation power and concentration in different markets. So some hospitals, whether it's just being the only game in town or acquiring other practices, are just really able to negotiate high prices.
So you got me to the punchline I was looking for, because in here, some of the RAND work was talking about one of the difficulties is sort of the collapse in competition because of consolidation.
That's correct.
Have you also worked through some of the data points of in healthcare markets, as if we dare use the word market, and something it's where the majority of money comes through government? Do we have a sense of in highly concentrated markets, single ownership or just one or two systems compared to any samples here in the United States where a market has lots of different providers, what we see in variance in the pricing just at that level?
One good example actually comes from the state of California. Northern California is very concentrated and dominated by a handful of providers. Southern California tends to have much more competition among hospitals. Hospital prices in Northern California are roughly double what they are in Southern California.
Say that last sentence again.
Hospital prices in Northern California are approximately double what they are in Southern California, which has a much more robust and competitive hospital.
So you believe that almost 100% variance in costs is just because of market concentration, lack of market concentration?
Correct.
Even with what CalPERS did of actually trying to do, their experiment from a decade ago when they were going broke and trying to find the best low-cost provider?
That's exactly right. And the CalPERS reference-based pricing model was really designed as, given the level of market concentration, lack of competition in Northern California, how do you get patients out of higher-priced Northern California hospitals?
Look, many of us on our side as Republicans, we like concepts like HSAs and this and that because we see it as empowering the individual. But some of us have actually much more, I think, disruptive visions of the thing you can blow into in your home medicine cabinet that instantly tells you have the flu and could order your antivirals. Has RAND or anyone out there done a study of saying, okay, here's adding competition in our healthcare delivery systems, but my ability to have a breath biopsy, the thing on my wrist that manages my blood glucose, if obesity and diabetes are the #1 drivers of healthcare expenses in the United States, you would think as a group here, we would be passionate to talk about if 33% of healthcare is just diabetes, if maybe the #1 killer of prime-age young men is obesity, we would actually talk about things like that. Have you seen anyone start to do studies of that ability to almost have your own medical lab on your wrist?
Not quite to the same extent, but one really good example, and I think one of the benefits of price transparency is how it enables that type of innovation. So for example, we've done a study of a program that developed bundled payment programs, and so instead of kind of going across a variety of providers to get service, can everything be bundled into a single provider? And that type of innovation and use of price transparency reduced prices for surgical procedures by about 45%.
Interesting. Doctor, thank you. Thank you, Mr. Chairman.
Thank you. Mr. Blumenauer is recognized.
Thank you, Mr. Chairman. I find the witnesses fascinating. I think the purpose of this hearing is extraordinarily useful. One of the things that's sobering is that we are paying more, a third more, we're paying almost twice as much as typical countries, and Americans get sick more often, they take longer to get well. We've got serious structural problems here. This is a very complex issue. There are lots of results. One of them I would suggest is that we are paying, we are subsidizing a diet that makes Americans sick, and half of the public suffers from diet-related medical conditions. The results are sobering. We have actually lost ground in terms of life expectancy from 79 to 76 years. Black life expectancy is 5 to 6 years less. These are very sobering circumstances. But I think we have, in the course of the witnesses' presentation, we've got, I think, glimmers of hope where people can come together. And the debt ceiling crisis that is enveloping us here, and I think we end up making it more complicated than it should be. But as a practical matter, the debt ceiling and the national debt is driven by health care costs. We're going to be spending $1.7 trillion next year, and it's going to rise to 12.7% of the gross domestic product in 10 years. We need to get health care under control, not only because of the lack of results, but that is an actual fundamental structural weakness in our economy and our country. I am intrigued by one little thing. Mr. Schmucker and I have introduced some legislation that would promote direct primary care. The typical general practitioner sees a patient about every 8 minutes. And they're lined up, and there's a huge amount of administrative overhead. A number of you have referenced that in terms of your testimony, Mr. Short. I appreciate your reference. This is an opportunity to shift so patients will pay by the year, not by the visit, and they receive incentives to use the care. Mr. Chairman, I hope that this is an area that our committee can be involved. Direct primary care, get rid of fee-for-service for more people. It's just a minor adjustment in terms of the IRS, in terms of what you defined as insurance. Direct primary care should not be insurance. We ought to be able to make this adjustment with the legislation that Congressman Schmucker and I have introduced that would be an important small step towards squeezing some of the excess costs out. It's more choice for the individuals. It's better for individual business. And it's a tangible step to be able to get more value out of the system. Mr. Short, you referenced it. I kind of went off on not a tangent, but I'm setting you up. Do you want to just elaborate a little bit on your testimony about how important being able to have direct primary care would be?
Yes, absolutely, and thank you for support on the issue of direct primary care. The basic concept of direct primary care is that we're taking what would be an actuarial value out of the insurance plan and pushing it directly to the healthcare primary care providers, may they be physicians, nurse practitioners, and physician assistants. And by doing that, you change the incentives. You're aligning up the healthcare provider to be incentivized to keep individuals healthy. I referenced in my testimony about one employee at one locksmith company who was proud of the fact that he had not been to a primary care physician in 20 years. And that physician, that primary care relationship, that direct primary care physician had a duty to then get him into a physical, into a wellness exam, and discovered he was type 2 diabetic.
Yep.
And he was paid, so the physicians get the payments directly through this arrangement. There's no overhead, there's no revenue cycle management. This is critical in terms of beginning to bend the cost curve for everybody.
Thank you, Mr. Chairman. I appreciate your patience. This, to me, is something that doesn't need to be partisan. It's very direct. It doesn't cost anything, and it improves health care. And I look forward to working with you and Mr. Schmucker to see if this is a little thing that we can get across the finish line. Thank you very much.
Thank you, sir. Mr. Winstrup is recognized.
Yeah, thank you, Mr. Chairman, and I want to thank you all for being here today. I'm very pleased that we're having this hearing, and I'm glad to see a practicing physician here on the panel today. I think that that's been missing very often when we get together, and it's important. And my home state of Ohio is pretty well represented here today. I'm with Dr. Panecki and Ms. Troiano. Thank you very much for taking the time to be here, and really to all of you for that. You know, as a surgeon who sees patients, you know, I've seen the change in our healthcare system that I think has brought us down. Ms. Troiano, you really touched on it. When you had a child 45 years ago. You know, we're just talking about direct primary care. I'm in favor of direct primary care, but that works well for a primary care physician. But it's harder for a specialist to operate under that circumstances. People aren't going to pay a fee for a specialist they may never need to see. So we have to figure out some way to make that work better. But, and I also think it's important, too, that we focus on health, and Mr. Blumenauer brought that up. And if, because prevention costs nothing in the long run. When you prevent something from happening, or you stay on top of things, and we focus on keeping people healthy, and it's not just what we're doing in medicine per se, but what we're doing with how we feed our nation, those types of things. We got to address all of this if we're going to be successful and really drive down costs. But someone else was, I think it was Mr. Thompson, talking about these bills that are so high. Well, I can remember, as a foot and ankle specialist, over a fourth of your bones in your body are right there. And so sometimes you're doing multiple procedures on one patient. And so the standard was, when I started in practice, you bill 100% for your most expensive procedure, and then you do 50% for the second, and 25% for the third, and 25% for the fourth. And then what would happen is insurance companies, when you did that, they would take the second one that you billed at 50% and cut that at 50%. And then they take the one that you billed at 25% and cut that down 25% more. So the game was starting to be played. And so we had to start billing everything at 100%, stamping the claim saying all procedures billed at 100%. Well, that led to a lot of lack of transparency for patients, and it was just a game being played with the insurance companies. But that's why you started to see bills like that, because if you didn't bill it all that way, they were going to do it in an unfair practice. So there are a lot of things to do, but we passed the No Surprises Act. Unfortunately, the HHS decided to change it when we made it very clear in a bipartisan fashion what this bill was supposed to do. And that's made it more difficult for patients. But there were a lot of things in there about transparency. We passed it in December 2020, required the advanced explanation of benefits. You're probably all familiar with that, a separate tool intended to improve price transparency. And this required that health insurers provide patients with basic information such as estimated price for a scheduled procedure. Now, these are your non-emergent things. Whether or not the medical provider or facility providing the service is in their plan, they should be able to tell them that. Whether or not the patient would be subject to utilization management services like prior auth and step therapy, two things that we're trying to fix here. I would have patients say, how much is it going to cost? They say, well, here's what I charge, but I could charge $1 million because the insurance company is going to tell us what it is, and that's a problem. So we tried to eliminate that with this bill. We're here over a year past the date. HHS has yet to even begin the rulemaking to implement these common sense patient protections. Dr. Poniecki, Congress did amazing bipartisan work on this, and if implemented correctly, this will serve as a meaningful price transparency tool for patients. Can you walk through how transparent pricing works for you as a doctor and what it means for your patients?
Sure, and I appreciate the time. Yeah, the important thing is, number one, you have an apples-to-apples comparison. So I think we've made impressive steps in the transparency front to try to get prices out there from the hospital systems. Right now, it's not apples to apples. I actually went on there a few weeks ago and looked up a CPT code for a joint replacement at one facility, and it was $1,352 or something like that. I mean, I don't know where that number came from, but I guarantee you that wasn't the price. The implant's significantly more than that alone. So we really need to kind of drive that forward a little bit more. And so I'd love to see a bundled price for services provided. And we've talked a little bit here about the emergency services, and that's absolutely essential and imperative. But the vast majority of surgeries and procedures performed are scheduled elective procedures. And so, hundreds and thousands of gallbladder removals and hernia repairs, and foot and ankle procedures, bunionectomies and whatnot. So it can be done. The impetus is on the physicians, on me and on my colleagues to provide that pricing for our professional services. And I think we need to push forward that with the facilities. And we actually need, as much as we can, have a bundled price for the services provided. I know what goes into it, and I've been doing this for 13 years. The hospital systems are doing a lot longer than I have, and have outpatient departments. So I would say we need to drive that forward, and patients will benefit from that, regardless of their socioeconomic classification or political leanings.
We did well when we had our own doctor's own surgery center. It was much easier. And my time has expired, but Ms. Triana, thank you for the transparency you're trying to bring in medicine. We'll talk further. I yield back.
Thank you. Mr. Pascarell is recognized.
Thank you, Mr. Chairman. I want to associate myself with the words of my friend from Ohio. I know we don't agree on too much, but I thought you're speaking to truth. I think that's a worthy objective. And the example you gave is a perfect example of what we're dealing with in healthcare. Let's be honest about it. Regardless of which subject within healthcare, we're dealing with those kinds of games that are played on us, and we play many times on the public to let them think we've solved the problem. I have a question to start at Dr. Gilfillan, if you would. Welcome aboard. Great witnesses today. You note that a new report, the Center on the Budget Policy Priorities, indicates that HSAs have become tax shelters for billionaires. Can you unpack HSAs have been exploited to profit the rich and not help regular Americans?
Certainly, Congressman, it's pretty straightforward. If you have discretionary income to put into an HSA, then you benefit from the tax avoidance associated with that. And you put some money away for a potential medical rainy day, if you will. If you do not have discretionary income, you're not in a position to do that, and most employers are not doing it. That's why the number of people with HSAs remains low. So employers liked the deductible idea, and they've proceeded with that so that almost everybody has a deductible. But that saved money for employers. HSAs were a cost. Funding HSAs would be a cost. So that has not caught on, and as a result, we have exactly what you've described. Wealthy individuals using them to shelter some of their disposable income and wealth.
This hearing comes at a very interesting time, as you well know, everyone knows. We're staring at a financial doomsday. This crisis imperils the health of this nation. It imperils the health, particularly of 60 million people on Medicare. So we have days left before we fall off the cliff. In some of the testimony today, we would have us believe that the American people need more information to protect our healthcare system. See, that's what we don't see. We're not getting enough information so that we can go from one side of the border to the other side of the border and understand what's at stake here. But when your health is at stake, everything's at stake. That's true when we are shopping for routine and predictable needs, like selecting a primary care physician or scheduling your annual dental cleaning. But if we are in health crisis, or God forbid, your child was in pain, that is not the time to try and become an expert in medical billing. Americans are adept at balancing value and cost. They do it every day at the gas pump and in the grocery store. Our constituents are smarter than we think, and they know the value of a dollar and stretching budgets. But when we're talking about catastrophic, once-in-a-lifetime critical care, transparency and pricing is not enough. This committee must look at Wall Street firms bilking Medicare, another report about how they're bilking and how much they're bilking for, and squeezing seniors for every dime. And I'm just flabbergasted by a report, which I missed. I read the report and I didn't really focus on this part of it. This report was outstanding. The National Bureau of Economic Research study. They found that private equity nursing home ownership resulted in the premature deaths of 20,150 nursing home residents between 2012 and 2017, not the pandemic. And that equals about 160,000 life years lost. The study authors also found that private equity ownership increased the use of antipsychotic medication by 50%. That's often a proxy for insufficient staffing, as you well know. Medicare billing by 11%, and the chance of death by 10%. So, tomorrow we're going to be talking about the pricing of Medicare. Today we're concerned about who do you turn to. And the questions and comments from both sides of the aisle I thought were excellent today, as were all the responses. We may disagree on some things, but if we don't know what the problem is, Doctor, we're not going to solve the problem, or maybe we'll get lucky. I yield back.
Thank you. Mr. Arrington is recognized.
I thank the chairman and the witnesses for their time and insight. Healthcare is very complicated. I truly believe we all want to make it more affordable for our constituents, for the American people. I think we all recognize the system is failing patients. We may have the best physicians and the best technology and the best facilities, but this is an embarrassment in that we can't get any of those things to function efficiently for the desired outcome. By the way, a desired outcome that we would all agree on. I agree and disagree with you, Dr. Gillifan. I find myself agreeing on the monopoly forces aspect to your remarks. We talk about big government being inefficient, convoluted, and making things more complicated than they should be. I personally think markets are the best way to achieve best value. If you have a healthy market with true choice, transparency, informed, empowered consumers, and real competition, among other things, competition being at the heart of it. And I think that competition is stifled by big medicine, big pharma, big insurance, big hospital. So I am very sympathetic, and I think I would agree with you that I guess I would summarize it by saying we're neither fish nor fowl. While I reject government-run healthcare, because I've seen government-run programs and they were miserable failures, not because there weren't good intentions, but it just doesn't, it will never function the way it should for the consumer, for the customer. But today, it's part government-run, part private-run, and people are so confused, and we're just not serving anybody well. Let's just all acknowledge that, right? But I do think people are rational and logical. But your point is the system isn't logical or rational, and so it makes it more difficult. I agree, but let's shine some light where there's darkness for consumers to understand what it is they're getting for their money, what other options they have, who is the best at delivering the services, et cetera, et cetera. I think Mr. Pascrell said it well. Our constituents and the American people are so much smarter than we give them credit for, but who in the world could navigate this system? So I think everybody would agree that now, I think we need not more government central planning. I think that will make it less efficient. I think we need healthy market forces, and we should unleash those market forces. And when we do, including more competition, Mr. Gillifan, and less monopoly forces. Man, I wish we'd have that conversation and that debate in here. But on the drug pricing side, me and some of my Democrat colleagues were able to pass what we call Shop RX. And it essentially allows for, it basically requires insurance providers to provide to physicians and patients information, as I mentioned, on the different drugs available, generic included, branded, the cost, where they can find it. I thought this was a step in the right direction, especially for our seniors. It gives them that real shopping experience right there at the touch of a smartphone and in consultation with their physician. This is 2.5 years later since we passed the bill. CMS has still not promulgated a single rule to implement it. So, Dr. Whaley, I just want to ask you, I mean, is this a tool that's going to help seniors if we can actually get the government? This is why I have no confidence, by the way, in a government-run system. It's almost 3 years later, and we can't even implement what we think is a small step to transparency and empowering seniors so they have real choice. Any comments, and then my time has expired.
So just very briefly, it's likely that we'll potentially see much more patient engagement, including among seniors, for drug price transparency and price shopping for drugs than for other types of medical services.
Thank you, Dr. Whaley. Thank you. Dr. Davis, you're recognized.
Thank you, Mr. Chairman. You know, with Sunday being Mother's Day, I can't forget my mother driving into us the idea that an ounce of prevention is worth much more than a pound of cure. And so when I think of health care and transparency, I often think of prevention, and I also think of a patient's right to know. And what that really is designed to do is to give the patient a sense of feeling of assurance that I have the best understanding of healthcare delivery, of the system, and what I need to do in order to get from it what is best for me. I don't believe that healthcare can be treated the same as marketplace choices. There's so much complexity. It's so difficult to know. It's so difficult to understand. But I do believe that if we put more focus on prevention, if we're really talking about reducing costs, bringing down the cost, if we put more focus on prevention as opposed to after the floods have come, you know, then we start talking about flood control. But if we prevent the flood from occurring, if the idea is to save, Dr. Gilfillan, you outlined 7 principles in your testimony. I've read them carefully and looked at them. If we really wanted to get at this business of reducing costs, how does those principles align with your thinking?
Well, thank you, Congressman Davis. I think I agree. Prevention makes sense. It's important, and I also agree that primary care is critical to making the system work. I happen to think that primary care is best embedded in a larger system that is accountable for delivering better outcomes. And so I believe accountable care organizations with primary care capitated within them, as some have proposed, is actually a great way of getting providers interested in actually doing significant preventive health care work. The problem today with fee-for-service is no one is actually benefiting from providing preventive care. So we need to create a structure of accountability where providers are thinking every day about what can I do to keep this patient healthy every time I see you. And I think it's correct. We don't want someone just seeing someone for 10 minutes and moving them out so they can check a box and get one payment. We want them thinking holistically about every patient and their population. And I believe that's best done through accountable provider entities, as I mentioned in the principles. So that's the path I would take. Capitate primary care within a broader, accountable system of care where we hold providers responsible for improving outcomes and decreasing the overall cost.
You also indicated that comprehensive health insurance coverage for everyone would be a good approach. What do you mean by that?
Well, I use the term comprehensive by saying that to mean that we should eliminate deductibles and coinsurance. We should open the doors to people going to get the care they need and then have primary care available readily to provide that care and to help them avoid becoming ill. So comprehensive, not with hurdles or obstacles to care, was my intent. And we need it for everybody. Today, we actually have created a multi-tiered system where the wealthy get what they need and lower-income families have a hard time getting the care they need. And they often, they're in communities where we haven't adequately funded hospitals or other services. And they haven't attracted the private equity that has found their way into other segments where there's more money to be made. So I think it needs to be comprehensive coverage for everybody at the same price, so that if I'm living in an inner city or in a rural area, my provider will be paid just as well as that provider in a wealthy suburb and is able to build the structures and the care systems needed to keep me healthy.
Thank you, Mr. Chairman. I yield back.
Thank you, Dr. Davis. Thank you, Doctor. Dr. Ferguson.
Thank you, Mr. Chairman, and thank you all for being here. Ms. Troiano, thank you. I hope I said that right. You know, being from Georgia, I can add an extra syllable with ease. So, but thank you for being here. And as a small business owner, thank you for your testimony, your insight, and thank you for fighting through and keeping on. We do appreciate that. So, Mr. Whaley, I'm going to kind of start with you and just kind of give us some insight here. Just simple questions. Right, compared to a decade and a half ago, is healthcare, or is the cost of healthcare in America more or less at the individual level than it's been, than it was 15 years ago? Americans paying more now than we were.
Substantially more.
Substantially more. Is America more healthy today than it was a decade and a half ago?
Not to the same level at which prices have gone up.
Okay. Is there data, and a genuine question here, does data exist that shows utilization of the system through different income groups? Meaning, we talk a lot about access to care and creating access to care. Access to care is very different than utilization to care. Are you aware of data that exists that shows that people in different income stratas, even if they have access to care, do they utilize that care?
We do know, not through a single data set, but through data sets that we've been able to piece together differences in utilization and types of providers based on broad differences in income.
Okay. With that, if you, and again, I'm going to put my provider hat on of having a private practice, a dental practice, in which my patients, whether they were Medicaid patients, whether they were employed by one of the major employers, whether they had unlimited wealth, all of my patients got treated the same. Same appointments, same access, just the way that we operated. And what we found is that even if someone had access to care, many times on the lower end of the spectrum, because of a variety of other issues, and emergencies that they were dealing with and the fact that they were living in the crisis of the moment, they simply didn't access the care. They didn't utilize the care. So when we talk about price transparency, and we should, because I think it's I think it's important for Americans to know the real cost of health care. I think it's important that we all understand the real cost of health care. I think it's important that employers do, and we're able to make decisions based off of that. Does transparency solve all of the world's problems? No, but it is clearly an outlet or an inlet for us to understand cost in the healthcare system as patients and employers do. But shouldn't we be transparent in the data as well, and how different groups are utilizing the system? Because if you have a group that may have access to care, but they're not utilizing the care, is that creating a problem in terms of still having the catastrophic events that drive cost up so high? I mean, Ms. Troy, no, again, I'm sorry. But with your employees, do they all utilize the system the same way, or do you have employees that only go in at catastrophic events?
We encourage our employees, everyone who's on our health care plan has to see their primary care physician at least once a year. So they have to turn in a biometric screening to a company, and they are required to do that. Part of the problem is the insurance companies are a big part of this problem, because they dictate to the primary care physicians what lab work they can have done. They dictate what tests need to be run.
Let me grab you, because I agree with you on that, but I've only got a few seconds here on this. But price transparency and understanding where those dollars go is obviously important, particularly at the hospital level in the enforcement of the rules. But Dr. Whaley, can you provide us, or be willing to work with the committee to get utilization data across the board, and maybe work with whoever you need to, so that we can understand not just access to care, but utilization of care and consistent utilization of care, and the lack thereof, what is it doing to lead to these higher costs? So,
Absolutely, and I agree that that's critically important.
Thank you, Mr. Chairman.
Yes, sir. Recognize Ms. Sanchez.
Thank you, Mr. Chairman, and I want to thank all of the witnesses for their testimony today. I want to assure everybody that Democrats are committed to affordability and transparency in the healthcare system, and that's why now more Americans than ever have healthcare coverage. It's why America now pays no more than $35 per month for insulin after we passed the Inflation Reduction Act. And it's why we worked with our colleagues across the aisle to pass the No Surprises Act. However, I'm a little disappointed because my colleagues today are promoting transparency in the name of a patchwork of healthcare options that primarily benefit wealthy Americans. I didn't have time to shop for the best emergency care when my son was hit with the face in a baseball when he took a line drive at third base. And sexual assault survivors don't have time to shop for forensic medical exams after they've been assaulted. In fact, that's why I worked with my colleagues across the aisle to introduce the No Surprises for Survivors Act. I think we can probably all agree that there should be more transparency in the healthcare system, particularly with the increase in consolidation and private equity investment. But claiming that patient choice will magically move the needle in affordability, I think, is misguided at best and disingenuous at worst, particularly when my Republican colleagues are working to push the U.S. into default, causing a 22% cut to the Centers for Medicare and Medicaid and Health and Human Services. Dr. Gilfillian, the research in Mr. Campion's testimony shows that there is no correlation between cost and quality. In fact, when patients have been offered online price transparency tools, they actually spent more than when they did not have access to those tools. Can you explain that? Why, would you say that the average patient is able to identify high-quality and cost-effective providers?
Congressman, quite honestly, I cannot identify high value and high quality providers in any way other than actually going around and talking to people who are close to the delivery of care in any particular institution. That's what I do when someone asks me for a recommendation, because the data we have is poor. It would be better to have more information, more data, more transparent data, and more structured data via registries or the report outcomes I mentioned that actually give us the chance to do that. But right now, you can go online and look at 3 or 4 different quality rating tools and find the same provider rated high or low on those tools. So no, there's not an ability to actually do that today.
Thank you. And Dr. Gilfillian, many of these employer-based consumer-driven healthcare plans that the witnesses are highlighting are effectively high-deductible plans. Those plans don't guarantee availability of providers in their area, nor do they promise consumer protection for additional medical bills. The majority of healthcare services are not even shoppable. And the facts are clear. Today, 1/4 of Americans delay needed healthcare due to the cost. It's not incumbent upon those patients to have the time and knowledge to bargain shop for their healthcare, like shopping for a plane ticket. I don't think that we can expect working families with no healthcare background, no understanding of the thousands of CPT codes, conditions, and plan types to be able to navigate a system that even payers have trouble with. I mean, when I had to switch my healthcare plan at the beginning of the year, it was difficult for me to figure out how to do that, and I'm an educated woman. Would increased price transparency help working families, particularly Latino and Black families?
I think the reality is, as I've said before, oftentimes the choices of providers are limited. Transportation is limited. So individuals in minority communities who may be in a majority or a significant number are in communities that do not have access to alternative care delivery are actually not benefited by seeing all that information, I believe. I think generally it's good for us to know, but the reality is that many of these additional high deductible plans are actually mini med plans, mini major med plans that leave individuals and families exposed to even greater bills when they actually go outside or they actually get care from parties that are not connected to those bills. So I think it is, I would agree with you, at times disingenuous to say that there are opportunities to decrease costs across the total spectrum of care by 30 or 40 or 50%. That's simply not the case. It hasn't been proven, and it hasn't happened in the 20 years that I have seen these kinds of programs promulgated.
I thank you for your testimony, and I yield back.
Thank you. Pursuant to committee practice, we're now going to move the 2-to-1 questioning. Mr. Estes, you're recognized.
Well, thank you, Mr. Chairman, and thank you to our witnesses for being here today to discuss this important issue of transparency and healthcare pricing. You know, there's so many issues in our healthcare system, and we've talked about several of them today, but there's no one solution necessarily that's going to solve all of them. You know, what you need for emergency care, what you need for planned procedures, what you need for preventive care, all different. And what we have to recognize is that some of those solutions do solve some of the problems, and it can't just throw them out because they don't solve all of the problems. Last week, we learned that inflation had gone up again. Americans are now paying 15.3% more than they were when President Biden took office for the same goods and services. And in a lot of medical procedures, that's even higher than what it was a little over 2 years ago. We know what prompted this rapid increase in inflation: massive federal spending. So while Kansans have had to watch their spending habits, Democrats in D.C. have pushed out over $11 trillion in spending, which has brought us to the limit that the federal government can borrow. As they struggle to stretch the same dollars to do more, Americans have a right to know how much the doctor is going to cost them. As we look for ways to curb federal spending and bring the federal deficit under control, we can look to a growing body of evidence that suggests a link between price transparency and reductions in federal health care spending. Healthcare spending currently represents 18.3% of our GDP. 1 out of every $4 the federal government spends is on health care, and that figure is projected to rise to at least 35% over the next decade. Premiums and deductibles in private plans are rising more than wage growth, and Medicare's Hospital Insurance Trust Fund is projected to be insolvent in 2031. These numbers are troubling. But the data shows that increased healthcare price transparency could help reverse the trend. If transparency results in a 1% reduction in cost, that could eventually lead to a $4.8 billion reduction in federal spending over 10 years. Mr. Campine, if these transparency rules were improved, what are the economic outcomes and what can we expect to see in terms of costs for high-cost services?
So specifically, which set of rules?
Well, in terms of as we put in more rules around having transparency around especially providers and...
Yeah, great. So I'll just give you an example. A retail client of ours, a patient requiring a joint replacement, received a $150,000 joint replacement. This isn't 15 years ago. It's not 20 years ago. This was in the past year. This hospital was in the lowest 20% of all patient outcomes in the United States for hospitals that we score that do joint replacements. There was a hospital 30 miles down the road that does the same joint replacement in the top 20% of all hospitals, and they're roughly $35,000. We have enormous differences in price and in quality for these services. Being able to navigate and being able to align the benefit design so that we reward patients for using high-value care and discourage the use of low-value care has a huge opportunity to save not just for the employee themselves, but also for the employer plan sponsors. When we look at this data, there's been a lot of discussion so far today. Roughly 40% of the total spend for any given employer could be shopped. Within that spend, easily half of that spend could be saved. So there's a significant amount of money that's on the table. What I'll say is over a 20-year period, we've seen utilization of our tools grow and utilization of those higher value providers increase, enabling those employers to incrementally grab more of that savings that's sitting on the table. There's a ton of savings that's still there. I think that's the opportunity that's in front of us through the ability to price more of these services and align the benefit design with what we want, which is better value.
Yeah, I mean, you know, as we've talked about, at the heart of healthcare is people, yet ironically, healthcare is one of the few systems where individuals don't know the price of services that they receive. Dr. Whaley, while the hospital rule has shown some promise, we know that not all hospitals are the same. In Kansas, we have the second most number of critical access hospitals at 82 compared to only Texas at 85. Many critical access hospitals focus on getting patients stable and then moving them to larger medical centers that are more equipped to handle complicated cases. With compliance around these transparency rules so low, what considerations or resources are necessary to help some of these critical access hospitals come into compliance without being burdensome or one-size-fits-all?
I think even for critical access hospitals, compliance and posting prices for the shoppable service is important. When we've actually looked at the types of hospitals that are actually non-compliant, it's actually not many of the critical access hospitals, it's many of the large nationwide systems. And so it doesn't seem like it's a resource problem with compliance, but rather an enforcement problem.
All right, thank you, and I yield back.
Thank you, Mr. Issis. Ms. Miller, you're recognized.
Thank you, Mr. Chairman. And thank you, Ranking Member Neal, and thank you to all of you for being here today. Throughout my life, I've worn many different hats. Besides raising bison and many other jobs, I also handle rental property that I own. And when I rent out an apartment, I usually tell them what the rent is, what that rent entails, what they can expect from a utility bill, and what their responsibilities are and what are mine. That to me makes a lot of sense. Now, healthcare, on the other hand, we've all kind of established that nobody really knows exactly what the cost is. So we need to work on the price. I think patients would appreciate the same kind of transparency that I give in my little business. Dr. Whaley, through your research, would you say that currently the biggest issue in preventing the use of pricing data by patients, what is it? And what do you think the most common sense fix would be?
Thank you for the question. As I said in my opening remarks, price transparency, to be clear, is not a magic wand for the healthcare system. We've done several studies looking at patients actually using price transparency and trying to see where they shop. And while patients who do use these tools do actually save money, the reality is that many patients don't actually shop for care. And I think there are two main reasons for this. One, it's complicated to shop for care, and there's a reason that doctors go to medical school and patients don't, and if you're a patient, it's hard to navigate the system. This is also further complexity by the coverage of insurance. So even if you do shop for care, most of the savings in many cases actually go to an insurance company. And then finally, another reality is that many patients are directed to go to certain providers from their primary care physician. And if your primary care physician is employed by a hospital or healthcare system, which we've seen as a dominant trend in healthcare markets, then that provider oftentimes refers you to a higher price hospital. And so you as a patient just have little agency to actually shop for care.
I've had young physicians sit in my office and tell me that they have like $600,000 worth of debt facing them and they're just starting out in their practice. But to me, it would be common sense to empower patients to be good shoppers when what they're looking for. And a basic market principle is that the consumer makes the best decision when they have all the information in front of them. One concern that I have, though, coming from a rural area of West Virginia, is that there's not a huge capacity for competition because of how few options for care patients have. So even though the patients might have the price information, there won't be an incentive for providers to have competitive prices and increase quality. So Dr. Whaley, how can we overcome these price concerns in rural America and prevent higher prices in areas that might not have robust competition to ensure that the patients still have good, cost-effective care?
If there's only one provider in town, it doesn't matter how much information the patient has, that's not going to change their decision. And so in those types of markets, I think it's important to think about why are there so few providers? Is it the fact that in certain markets, other dominant providers have gobbled up the system and acquired other providers? And if so, are there antitrust or other regulatory policies that we need to have? If it's the case that it's just a rural area where maybe it's just kind of natural to have a single provider, then maybe there needs to be a different payment model that maybe equalizes payments across different payers for those types of providers.
It's sort of both of those. I've mentioned this before in health hearings because I worry that the fear of the hidden costs might prevent folks from actually seeking care, as many of these studies have shown. Dr. Pinecki, is there something that you've seen from the provider side? Do you think that transparent prices would alleviate some of the fear that the patients might have in choosing their health care?
They definitely have. Like I said, you mentioned about, a lot of rural areas. I spent a fair amount of time in West Virginia, a couple times a year on average, just for vacation purposes. I just enjoy the area. And so I've got a chance to know the folks in those areas, Beckley and other areas around there. What typically happens is if provided the information, what we've found in the last couple of years is that patients will in fact be good consumers. They're active consumers of their care. They will invest the time to find out, hey, where is the best option for me, not only from a cost standpoint, but from a quality standpoint based upon the metrics that we have available right now, which are incomplete but are getting better. And they'll actually travel for that care in a lot of cases. So, it's been quite impressive just to see patients taking ownership in that, but they have to be given the tools from a transparency standpoint to have the resources to do so.
Thank you. I yield back.
Thank you. Mr. Higgins is recognized.
Thank you very much, Mr. Chairman. Dr. Gilfillan, how do you characterize a high deductible health plan as it relates to patient protections and patient services?
Congressman, excuse me. I believe high deductible health plans actually reflect, in the employer market, actually reflect the fact that employers were frustrated with the ability of insurance companies to get adequate pricing, to have lower costs, and therefore made a decision to pass on responsibility for those costs to their employees, some of whom can afford it, many of whom cannot.
But doesn't that, by its very definition, discourage people from using the health care that they already pay too much for by jacking up premiums, jacking up co-pays, and jacking up deductibilities? And then when they go to use the health care that they pay too much for, there's very little underlying health care.
It has been shown, I believe, that cost sharing, whether through deductibles or high co-insurance, do result in patients avoiding necessary care and unnecessary care, almost in a way that's undifferentiated. It's a truism in the industry that if you put hurdles in the way of getting care, financial hurdles, people will access less care.
So doesn't that take us back to pre-Affordable Care Act with all the patient protections, the inability of an insurance company to deny somebody coverage because of a pre-existing condition, the 10 essential health benefits that all healthcare plans have to provide? It seems as though this is moving way back to a place that, I think in terms of patient care is not a good place.
Well, certainly the Affordable Care Act created the remarkable result that many more people at least have coverage, so they are not exposed to the catastrophic financial and family impacts of having no insurance.
35 million more Americans have health care because of the Affordable Care Act. And health care is delivered by professionals, doctors, nurses, specialists, and how you pay for it is a combination of private pay and public pay. Right now, the annual health care cost in America is about $6 trillion. 1.9 trillion of that is paid by the federal government through Medicare, Medicaid, the Veterans Administration, and general tax treatment. It's a lot of money. It's about 30% of all healthcare spending paid by the federal government. But doesn't it also give us leverage to knock down the cost of healthcare and build up the quality of healthcare?
I believe it can, and in some ways it already is, through a variety of programs, many of which were in the Affordable Care Act, such as the Shared Savings Program. CMS is actually making great strides towards improving the delivery of care. It's also more efficient. The reality is the cost of administering Medicare is about 2% compared to the 15% that is taken by commercial and Medicare Advantage insurers.
And aren't those private payers? I mean, if you look at the compensation scale of some of the, well-known national, aren't they incentivized to cut costs, which is an incentive to deny people coverage for the insurance that they're paying for?
I think they're incented by improvements in stock prices. And everything they can do to increase stock price, they do. And that includes decreasing the cost of care.
Denying coverage.
Denying coverage is not so much the issue for individuals at the level of providing a service, yes. In my experience at Trinity Health, large national insurers were denying or downgrading 30 to 40% of our inpatient claims. They were doing that on the backs of providers, if you will. They were insulating patients from some of that, but the fact was they were denying care and at times, obviously, denying coverage for specific services.
Thank you. My time's expired. I'll yield back.
Dr. Murphy is recognized.
Thank you, Mr. Chairman. I'm going to piggyback on Mr. Higgins because you're exactly right. Insurance companies get paid to deny care. Period. Period. That's what we were trying to do with the No Surprises Act. And you, Doctor, you spoke about that earlier, but we sent them, the Biden administration, a great bill that put a balance between insurance companies and doctors. Bipartisan, bicameral, Biden administration, everything to insurance companies. Everything to insurance companies. I think we've gotten a little bit, I appreciate everybody's comments today, a little bit off track. Healthcare is not a market economy. Why? Because the government's involved. Because the government's involved. That's one of the main reasons. So if I will, I'm just going to say, why are things more costly? By the way, since the ACA has come in, insurance has doubled 129% from 2013 to 2019, what people pay for insurance. It's 129% up.
Yes, there are more people covered, but it's all shifting. So to say it saved people money is absolutely false. Why are insurance companies, ma'am, you spoke about earlier about the cost when you saw this. I remember when my dad passed away, he got an insurance bill, 1979, in the hospital for 6 weeks, cardiac surgery, complication, and died. I think our bill was $25. Why? Let's look back and see why this is, because I know transparency is an issue, but honestly, guys, that's about 5% of health care. There's monopolies, there's rural care, mostly elective surgery. What's the number one determinant of which doctor you want? It's whether you like him, and does he work at that hospital, and do you trust him? And if you want to shop around for a knee replacement and you find somebody you trust, great, good to you, but that is such a minuscule amount of what we're talking about. Why are healthcare costs rising? Insurance companies. Insurance companies. Last year in the third quarter, United made a $5.5 billion profit. $20 billion for the year. Their CEO gets close to $20 million. Government regulatory burden. There's a wonderful little chart that I show over the last quarter century. The growth of physicians is about that. The growth of the administration and burden is like that. That delta is a massive provider. Cost of technology. Everybody's now has to have a robot in their hospital. I'm not saying that's good, that's bad, but I think we as physicians have gone way too much technology, and that's cost health care. Extortion of pharmacy benefit managers. Let's get hold of that for the price cost of drugs. The explosion, and I'll go back to diet. We talk about health. You can't go on any corner in eastern North Carolina and not find 15 fast food markets. And this is where diabetes, heart disease, obesity, where are all these things coming from? You can't make a patient take a prescription, buy a prescription, and do what you tell them. And where has the cost not risen? Physician pay. 22 years, 20% decrease. The people who are actually providing the care. By the way, hospitals don't deliver care. They're a building. Doctors and nurses deliver care. Let me ask you something, real question here. I'm sorry, Dr., I can't have a hard time pronouncing your name, Dr. Gilliflin. One thing that drives me crazy is insurance company CEO pay, but it's also hospital administrator CEO pay. Do you think hospital CEOs should be paid any more than the physicians in the hospitals who deliver the care? There's a yes or no answer to that, because if you've seen this explosion in the number of hospital administrators, where is the massive delta? And why do you see such an exodus of doctors today that are leaving? It's one of those reasons. Could you just rephrase that question?
Should CEOs be paid more than the physicians who provide the care in the hospital?
I think they should be paid close to what physicians make.
Thank you. I agree with that. I don't believe in these CEOs making $14 million, or some hospitals where 9 of the top administrators making $2, $3 million. It's just ridiculous. It's a slap in the face for the doctors and nurses who are taking the care. Let me just end up, we'll talk about the transparency issue. Medicaid, folks on Medicaid don't give a damn about it. They have a $3 copay and they don't care. Medicare, I don't care if I charge $175 million to take out a kidney, I'm still going to get paid $175. Now the hospital charge and everything else is different. I absolutely believe that we need transparency in healthcare, but what we truly need is to go after the items that I spoke about earlier that are the true drivers of healthcare cost. Get the government out of healthcare, get our insurance companies to go back and do what they were supposed to do, insure patients, not deny care, get pharmacy benefit managers back to what they were supposed to do rather than triple bagging now money, and get all these things out of healthcare. And then we would return to a system in the United States where it was supposed to be, where you don't go to Britain, you don't go to Canada, where people are denied care. Thank you, Mr. Chairman. I'll yield back. Mr. Kustoff is recognized.
Thank you, Mr. Chairman. Thank you for calling today's hearing, and thank you to the witnesses for appearing. Dr. Panicky, if I could with you, in your statement you talked about when you left the hospital, your prior position, due in part to lack of transparency. So it's your new practice, or the practice that you're at, you list on the website cost for all the procedures, from a colonoscopy to eye muscle surgery to a toe amputation. Everything's fixed, it's transparent. How do you determine what to charge for a colonoscopy, for example?
That's a good example. One of the important tenets of doing what I'm currently doing is that I feel a personal responsibility to taking the complexity whenever I can out of the care delivery model. So for example, colonoscopy, if you operate under the normal fee-for-service process and you submit your claims, you bill for each one of those pathology specimens you take, you can kind of run up the bill really, really easily in the traditional system. What we elected to do was say, hey, we understand there's going to be certain colonoscopies that are going to be done where no biopsies are needed. That's going to be X price to our business. And there's going to be certain cases where 10 are needed, and that's going to be, you know, a multiple of X price. And so we've just taken those numbers and looked at the data to say, hey, if we amortize that out, what does our cost need to be to cover our expenses and make a small margin, assuming that we're going to take 3.2 polyps out? That way, the impetus is not on the consumer to say, hey, I don't know if I'm a 10 polyp patient or if I'm a 0 polyp patient because my price is going to vary. We take that liability on our shoulders and say, hey, this is what we're going to charge for everyone so that we can basically offer the service in a non-discriminatory fashion so everyone's kind of treated equally.
Your practice, your clinic, you've got a number of the specialties, gastroenterology, ophthalmology. Going back to the colonoscopy just for a moment. So again, your prices are there, they're transparent. Do you adjust them X number of times a month, X number of times a year? When and how are they adjusted?
Since 2021, we did increase the prices probably about 4 to 6 months ago, quite frankly, due to inflationary costs. The consumables costs are still there, and the staffing costs. What we've tried to do, because with our model, again, we employ nurses and technicians, surgical techs, that have had multiple years of experience just because we want the best of the best as far as the clinical staff. We want to make sure that we're compensating those folks well, and you know the cost of living is going up. You know, so we wanted to basically incentivize the good people that we have there to stay there and want to be with us. And so there was one price increase in the last 2 years.
This hearing, and I think rightly so, has been focused on the patient and his or her ability to get care and to know what they're paying. If I could though, I do want to ask you about the practitioner, because you talked about the situation that you left and where you are now. We all talk to different practitioners in our districts. We know the frustrations, starting with the Affordable Care Act. Talk, if you can, about this model and the benefits to the doctor or the practitioner.
There's been a significant number of them. There's been some wins that we've had and some losses. I'll start out with some wins. A couple of the surgeon practices across multiple specialties that have agreed to provide clinical services at our facilities, they didn't actually know what compensation they actually needed. They just didn't know. They're just used to submitting their claims in the fee-for-service model, and they didn't really know what was fair. And so we just try to be generous and really kind of shift to Dr. Murphy's point. You know, most of the fee is going to the box, the four walls where the actual, you know, services are being provided, not to the ones that are providing the service. So we just try to compensate the surgeons well, and they're really thankful for that. And the other interesting part of that was, you know, they said, well, how do I get paid? And we just said, the end of the month, and we just write the check. And they're like, that's all there is to it. And quite frankly, that's all there is to it. One of the losses that we had was during COVID, we had a significant number of employed physicians associated with the hospital systems locally for us who said, hey, elective surgeries have been canceled. We're not actually allowed to operate, essentially. We have patients that need clinical services, surgical services provided, but we're not allowed to do that right now. I'm thinking about taking some time off. Can I provide services at your facility for patients that need semi-urgent, but still classified as elective procedures, and they were told no and couldn't participate, even though they were not actually providing any clinical services at all because all elective services have been canceled. And so, again, these are the frustrations that we've dealt with, and that's unfortunately one loss that we've had in the employed physician realm.
Thank you. Thank you. My time has expired. I yield back.
Ms. Chu is recognized.
Dr. Gilfian, you gave a very compelling argument in your testimony that the transparency in healthcare pricing that would allow patients to shop around for the cheapest price will not fix the problems that Americans face in obtaining healthcare. That's because on top of an inefficient healthcare system, we have a vast financial and administrative superstructure that takes away from the actual delivery of care. These are the insurance companies, private equity firms, and big pharma who are working for market dominance so as to reduce competition. Now, I do think there should be transparency and that we should all know what the cost of healthcare is in each market. But you make the strong point that asking America's families to address the shortcoming of our healthcare system when they are the most vulnerable seems inappropriate, ineffective, and has failed to date. And in fact, you give the example of a woman who has just found a breast mass and the impossibility of her being able to shop around for the cheapest health care. Can you talk further about that example and whether shopping for health care works?
Certainly, Representative. So it's easy to say, I've got knee pain and my doctor says I need an MRI, and therefore I look around for a cheaper MRI. But how about a woman who discovers a breast mass? What lies before her in her efforts to deal with it? Is she going to look and shop for an ultrasound? Is she going to go to a primary care doc who sends her one place for a magnetic resonance imaging study? Might be different from the place that she'd like to go to see an oncologist who's a particular specialist in this area, who might be centered at a hospital, an oncology specialty hospital, that may or may not be in the network of the insurer that they have, and may or may not have higher prices for one service and lower prices for another service when they go to look online. There's only a couple of codes, frankly, in the list of 300 or the 70 required shoppable services that actually address this. So then, if she unfortunately has a cancer diagnosed, where is she going to have chemotherapy? How is she going to shop for chemotherapy? How is she going to decide, as she looks around at prices for these 10 or even 20 different services that occur along the way in her course of care, what is the trade-off in her mind between price and quality? Does she think the lower price, the better the quality? Does she think the higher price, the better the quality? What is that trade-off? Are any of us equipped to make that kind of a trade-off? And I think the answer is no. And that's just one example of asking someone at an incredibly vulnerable moment to go out and plot their own path, not just to getting access to care, but figuring out how much it's going to cost as I get care at all those multiple stages.
Dr. Gilfian, it was back in 2019 with the Trump administration that there were 2 rules finalized for price transparency. And the Biden administration continued this effort by increasing penalties for noncompliance. So this has actually been bipartisan. But despite all that, it's been very difficult for patients to access pricing information, and it's especially difficult for those who lack health literacy or who are limited English proficient. So my first question is, what compliance rate is there of hospitals in terms of the price transparency? I know that there were 4 penalties imposed since the rule started. Is that a little or a lot? And then what about the health literacy issue?
Yeah, well, it's a little, I would say. I think we can all agree it's a little. I went online, by the way, at my old employer, Trinity Health, and looked to see what their compliance was. They are 100% compliant. The tool is nice, and by the way, they bought a standard tool from some vendor that put that together for many hospitals, so the industry is building that capability. My understanding from what I've seen is that about 70% of hospitals are compliant with various pieces, and hopefully they're making progress on others. But when you look at those tools, and when I look at the tools of my fellow panelists here, they're not easy. You know, I know CPT codes. I know more about CPT codes than most doctors because of being in the insurance business, right? It's not easy to identify to find the service you're looking for, the code, and more often than not, it wasn't there. And when I looked at the prices on some of these sites, quite honestly, the prices didn't make sense, as someone else here said. They're not consistent. So when you go out there and look right now, health literacy is an issue, certainly, but the basic data that is being provided in these third-party sites that are set up to help you shop just are not accurate.
Thank you. I yield back.
Mr. Fitzpatrick is recognized.
Thank you, and thank you, Chairman Smith, for holding this timely hearing on the much-needed price transparency in our healthcare systems and services. As we all know, the United States of America has the highest cost of healthcare in the world. In 2021, the U.S. healthcare spending reached $4.3 trillion, and according to the Congressional Budget Office, meaningful price transparency can add leverage and promote competition to reduce prices. And one of the goals today, obviously, was for all of us to explore this relationship between price transparency and cost savings in our healthcare system to better inform patients. My question, Dr. Whaley, is for you. Currently, hospitals are the only healthcare providers required to post transparency data. Do you believe the requirements should be extended to other settings of care in which patients can obtain shoppable services? And if so, which settings would they be?
Thank you for the question. Hospital care accounts for about half of healthcare spending, or about 45% of healthcare spending, meaning that there are many other sites of care where patients are receiving lots of care. I think if the price transparency requirements were to be expanded, there are many settings that would be natural settings, both in which patients receive lots of care, and it's also the shoppable types of care where patients are making these types of decisions. So these environments include places like ambulatory surgical centers, freestanding imaging and laboratory test centers, and potentially physician offices.
And providing access to price information obviously has been very important in my home state of Pennsylvania and our hospitals. In Pennsylvania, every hospital has a patient advocate or a financial counselor. These individuals are available to discuss pricing with anyone in order to clarify costs. Have you examined the benefit that a program like this can have on providing pricing information to patients?
Unfortunately, we have not studied patient advocates directly.
Okay. Mr. Chairman, I yield back.
Mr. Stubbe is recognized.
Thank you, Mr. Chairman. I think one of the things that obviously has come out through all of this is there's a significant lack of transparency in the hospital marketplace. I had the fortunate or unfortunate situation about 4 months ago to spend 4 days in the hospital. It was a trauma-type situation, so I obviously didn't have control over what hospital I went to and all of that. But just to give you kind of an idea of what I personally went through and have now a lot of information on this, I mean, at no point in time while I was at the hospital did anybody say, hey, this procedure is going to cost this much, or hey, if this doctor comes, it's going to cost this much. Like, there was no communication whatsoever on any prices on anything. And then this came about, I don't know, a month or two later, and this is the bill that I got. 5 pages, single space, of all these things that supposedly happened to me while I was there. Like, I broke my pelvis, I had a punctured lung. I don't know why I needed an EKG. Nobody asked me if I wanted an EKG. Maybe that's, the doctors are gone. Maybe that's just something they do, and they don't ask you. But, like, there was no communication with the patient about the procedures that were going to be done. Now, I got excellent care, so I don't want you to take what I'm saying as I didn't get good care. But from a patient perspective, there was no communication about how much, and this was, these 4 days, this was over 6 figures of just being in the hospital, being told, okay, this is what we're going to give you this. At one point, I was told, we're taking you in for a procedure, and he kind of explained what it was going to be before I went in there. And that's significantly problematic for patients, that when you get this in the mail a few days, well, a month or so afterwards, and you look at the numbers, and you're like, holy cow, like, there was no communication about any of this. It's obviously challenging. Luckily, we have health insurance, so there wasn't too much of a challenge there. You pay your co-pays. One of the other piece of it that was interesting that I've learned through this process is multitudes of doctors showed up during my 4-day stay, and I didn't know who these doctors were. They showed up, and then on top of this bill, I got other bills for the doctors that just showed up. I didn't know who they were. I didn't invite them to come in. I didn't say yes or no, I would like you to talk to me for 5 minutes to give your expertise on my broken pelvis. So there's some significant issues that have to happen, in my opinion, on the healthcare side for the consumer and the patient, regardless of whether it's trauma or not trauma. I mean, I was conscious the entire time, so there could have been communication. My wife was there the entire time. There could have been communication. So my question, and I'll open it up to the panel, is what can Congress do from a legislative perspective to breathe in some transparency so that when a patient like myself or otherwise, Americans show up at a hospital, regardless of what the circumstances is, there's some communication between the hospital and the patient of, okay, you're here for X, so this is what we're going to do. This is going to cost X amount. If you stay 1 day in the ICU, that's going to be $8,000. Do you have a choice as to whether you want to do this at home or come and do an outpatient? Like, I'm just asking you because you guys are professionals. I don't know. I was a patient. What do you think that we could do to breathe some free market transparency and some patient advocacy into the ability to be able to make those determinations? I'll open it up to anybody that wants to comment. Don't all jump in at once.
I got a couple looks over here, so I guess I'll take a
Yeah, go ahead.
start at that. One of the biggest things with the transparency, I don't know if you want to call it a movement, is that the more we are able to get numbers out there and accurate numbers, whether that be elective surgery, whether that be emergency surgery, whether that be emergent trauma care, whatever that might be, emergent imaging or elective imaging, the more we get the information out there to have comparative pricing, it's going to keep the bad players more honest. They're just not going to get away with things. And so I bet on that bill, if I had a chance to look over it, I could tell you from almost most of the line items, hey, this is reasonable, this is unreasonable. And that's just me. If you have transparency and actually have that data out there and have claims out there from the person that came before you, and this is what that hospital charged, it's just going to keep that hospital honest if they're not being honest. And I don't know if they are, but it's just going to level the playing field and actually have the information available. And then the bad players will be called out for it, just amongst the industry at large.
So requiring, just to kind of summarize what you're stating, just requiring hospitals and providers to provide information on what X service is going to cost, put it on their website or wherever, so that when a patient does show up, they know and have transparency. Like you mentioned radiology, I had apparently 14 units of radiology, and that cost $38,000. I don't remember all of those scans. I don't remember what they were. So you're just saying, like, if there was some information on a website that's public and available, and when you show up, you kind of have an idea. Am I summarizing that correctly?
I think that's fair. I'll give you an example. I don't know what 14 units of radiology means, but I'll use an example. You probably had an MRI or a CT scan. The hospital scheduled MRI is anywhere from $3,000 to $5,000. You can get that for about $700, with the same type of study done. And so when those numbers actually come out, if it were transparent what's being charged with any given system or entity, the systems will police themselves, right? At that $5,000 study, that the machine costs the same as the $700 study. If there's a 400% margin there's probably a local system, probably wherever you receive care, that's willing to say, hey, I'll accept a little bit less margin. Hey, we're not going to gouge you like that guy did. And so I think you'll start seeing some self-policing and a market correction with some of these major outliers.
Thank you. My time's expired.
Ms. Moore is recognized.
Thank you so very, very much, Mr. Chairman, and thank the panel for your long suffering through the Ways and Means Committee. Mr. Gilfillan, I noticed from your testimony that you talked about the creation of an all-payer payment system. Can you sort of elaborate on that and make the distinction between that and a single-payer system for us?
Certainly, Congresswoman, thank you. And I would say, in response to your experience, Representative Stubbe, pardon me, I think the all-payer approach is what's needed, and you needed the EKG, I'm sure, with those kinds of injuries. So I'm glad you had a good outcome from that. But an all-payer system says you've gotten that bill, and the hospital charges all sorts of different ways, and those are charges, not payment amounts, I assume. And that's because they're kind of free to do it their way. And every one of them, those 6,000 hospitals will do it their way. And every insurer is going to ask to get it their way. And an all-payer system would say, you know what, we're going to do this one way. Here's a standardized way of doing this. This is the way you should submit your bills. And by the way, what I pay you is going to be based on the rates that we have established for that particular set of services. And I don't believe shopping, at the hospital bed is really a viable thing to be doing. So I would take you out of that predicament and simply say, there's an all-payer system. Different insurers can use it and will use it, are required to use it. So we don't have this a la carte madness.
Got you. Thank you so much. You talked in your testimony about Medicare Advantage industry benefiting from government intervention, including subsidies. Many have bemoaned the fact that medical assistance is facing funding crises. So is the Medicare Advantage system better? Is it worse? Does it have more quality? And how does it interface with payments for medical assistance?
I think it's pretty clear. I think it's almost universally acknowledged that it costs more. How much is debatable? It's somewhere between 20 and 30% more probably. Some would say 10 to 25%, I guess would be more accurate. Definitely more expensive. In terms of outcomes and quality, it's debatable. MedPAC, the organization that advises you all, Congress, on Medicare policy has said it is impossible to determine and compare the quality of care in Medicare Advantage versus ordinary Medicare. And I would just go back to Congressman original point, Congressman Murphy, and say we do indeed have the worst. We have the worst of government, and we have the worst of business, marketplaces coming together to create a system which is unaffordable for all.
Let me ask you one other thing. There's been a lot of discussion about health savings accounts, and it's just unavailable to people who are low-wage workers, and I just want you to elaborate on that a little bit.
It certainly is. It's most families in America have limited savings. Many live from paycheck to paycheck and do not have readily available disposable income, and that's why the penetration of health savings accounts has been so low.
I just have one other question. I want to backtrack a little bit on my Medicare Advantage service. There are things like, exercise or swim classes or things that people on Medicare Advantage say that they get that you cannot get under Medicare, regular Medicare. How do you, is that the case? I mean, people prefer Medicare Advantage because they get those extra things. Yes. Just want you to comment on those differences.
Yes, there are extra benefits that are provided through Medicare Advantage. There still are copays, it's sometimes deductibles and coinsurance, so it's not free coverage, although the premium can be free. Yes, there are gym memberships. Yes, there are other services. Many of those supplemental services actually are not very utilized because if you're a person with no disposable income and you have the inability to pay to go to see a dentist, and now Medicare Advantage plans give you coverage for half the cost of going to the dentist, you still don't have the money to cover the other half. So it turns out that the use of those supplemental benefits is actually pretty marginal in most markets today.
Thank you so much. And Mr. Chairman, I would yield back.
Thank you. I will point out that 78% of all individuals who use an HSA make less than $100,000 a year. It's a pretty big number. Ms. Tinney is recognized.
Thank you, Mr. Chairman, and thanking Ranking Member Neal for holding this hearing, and thank you to our witnesses. Terrific job today from various perspectives. And almost any market, assuming there is a market, we interact with an American Life functions best, and we have the two necessities. We have access to clear information and transparent pricing, that is, if people really do have a choice. Without these qualities, it's impossible for the patient to know if their care is good, a good value for the price, and if they should be looking elsewhere for care. Again, we get to the question of, do they really have a choice? And I come from New York. A lack of market information and transparent pricing in our healthcare sector is just one of the many reasons, and there are many, as Dr. Murphy pointed out, that we've seen a rapid expansion in healthcare costs from premiums to copays and coinsurance. Our healthcare system is not failing because it's free market. It's because it's not a functional free market. And anyone who wants to come to New York to see among the highest healthcare costs in the nation, you can see how it's not working in New York. And as a family business owner, I can totally relate to Ms. Troiano. We face enormous pressures. We had health care for our employees, which we provided without a mandate because we wanted to be competitive against our neighbors, our competitors, and also government that was providing pensions and health care, and we were trying to lure great employees and great people to come to our company. But today, we went from a rate of about $5,000 a year for a family plan to over $29,000 a year for a small family business with about 60 employees. So we know this enormous cost is just really almost prohibitive for us to even stay in business because we can't compete against government on so many levels. So the so-called Affordable Care Act has made it almost impossible for us to stay in business and to actually have affordable, good care for our clients, not to mention the really high deductibles that we face. But I wanted to ask you, similar to the Clark Gray Vault, many of the small businesses I represent, as well as my own company, as I cited, have seen enormous interest in their healthcare premiums, seen increases in their healthcare premiums. In your company's switch from traditional healthcare insurance to the innovative SideCare Healthcare, how much were you able to save in premiums compared to what you were quoted for other plans? And have you been able to provide any additional benefits to your employees?
So Sidecar Health came in. Our original United Healthcare was our carrier for 6 years. They came in with a 35% increase. There were 3 companies that would not even quote us. They did a no quote on us. Sidecar Health came in, and actually our premiums increased 10%. So it was a palatable amount. It was an amount we could absorb and passed on very little to our employees. I think the employees' single care coverage went up $3 a month. We offer an FSA, not an HSA. Our employees like the FSA. We have a lot of participation. About 68% of the people who are in our healthcare plan are in our FSA. But they like the Sidecar plan because they don't have any funds going out of their own initially. It is all funded by Sidecar up front. They know the health care, and they're very good at shopping it. They are very good at shopping.
So those provide those additional items that you couldn't have provided otherwise.
We couldn't have provided them anything near what Sidecar has, where they don't pay anything for prescription costs.
Terrific, no.
Yeah, which is something that is a big part of our cost.
Thank you for that. I appreciate it. It's a great idea. Mr. Short, in your testimony, you outlined how the subscription-based direct primary care model has been effective in improving health outcomes and reducing costs for patients. Great to hear this. These are among the facts as a core reason why I joined my colleagues, Representatives Smucker, Blumenauer, and Schneider, to introduce the Primary Care Enhancement Act. Can you describe how direct primary care model reduces costs upstream and increases the quality of life for patients?
Absolutely. With the ability of moving the payments directly to the healthcare provider at the best set of the individuals, we're able to cut off a tremendous amount of overhead and then incentivize the individual primary care physicians to actually take an additional interest in the preventative health care. And by going after preventative health care as a means to offset future health care expenditures, we're able to bring down the cost of care, and also including that cost of care is reducing the cost of payment acquisition.
Well, how would you change our healthcare payment system now to make our healthcare sector more responsive for these cost-saving innovations like direct primary care? Quickly, we got a few seconds left.
So everything that's non-catastrophic, we need to move down directly to the patient and the provider relationship by increasing those payment accelerations, by reducing the account receivable and the payment cost of acquisition.
Thank you so much. I yield back.
Ms. Stills, recognized.
Thank you, Mr. Chairman. Our nation's inflation problem has shifted from goods to services. The jump in medical inflation is concerning, as rising prices for services tend to decline more slowly than for goods. On top of that, according to a recent LA Times article, healthcare spending now accounts for almost 1/5 of America's economy. I view addressing rising medical costs involves two matters: greater healthcare price transparency and more competition. I believe currently hospital price transparency doesn't work because it is not good enough, and CMS has largely failed to hold the hospitals nationwide accountable for non-compliance. So my question is to Mr. Campine. I am concerned about the quality, consistency, and usefulness of the data provided with the hospital price transparency requirements. Do you believe there is a lack of standardization and specification in reporting requirements?
Yeah, absolutely. Certainly. Yeah, that's part of the reason for some of the variability in the files that we look at. It's very difficult to work with.
Thank you for very precise answer. I really like that. And I also believe that increased healthcare price transparency paired with modernized healthcare options will drive value and temper the trend of rising healthcare costs. For example, telehealth has been life-changing for so many over the past few years, and we should remove red tape that prohibits families and individuals from having access to this option. This is why I introduced the Telehealth Expansion Act, and with Congresswoman Susie Lee and Congressman Adrian Smith and Congressman Brett Schneider. This legislation would make permanent a waiver created by the CARES Act to allow over 34 million Americans with the health savings accounts to access telehealth services without first having to meet their deductible. I also support improving both HSA and direct primary care access, which Congress Brett Wenstrup and Brett Schneider have been leaders on. So, Mr. Short, I believe telehealth access is vitally important for all religions of America. Late last year, the Ways and Means Committee worked in a bipartisan manner to extend the first dollar coverage of HDHP, high deductible health plan, HSA telehealth, after it had already expired only in 2022. As we get closer to next year, I'm very much concerned about this provision expiring again. We try to make it permanent, but every year we just barely extending 1 year. Last year we extended 2 years. What are some of the consequences of not having access to telehealth pre-deductible for the millions who have HSAs? And secondly, how would we improve access to HSAs moving forward?
Well, I think the ability to increase access, even when using technology through telemedicine, is critically important, because physicians are trained to know when someone's having bad Chinese food or a heart attack, and it's important that we have the ability for people to have access to care from all types of pieces to it, which would drive to different types of healthcare outcomes, consequences if diagnosed indirectly. So if you don't have access to telemedicine, easy access to care, you're going to see more people going to emergency rooms, which is going to increase the cost of care. And so how can we increase HSA access to more people? Well, it's getting HSAs for all, getting people to have the ability to have more access to HSAs regardless of the health insurance plans that they have. That's how I would expand all of them.
Thank you very much. I yield back.
Mr. Kildee is recognized.
Thank you, Mr. Chairman. And just a point of personal privilege, I want to thank the chairman, the ranking member, other members of the committee. This is my first time back to committee since my cancer diagnosis and surgery, which was successful. And I appreciate all the kind well wishes and support during that period. It meant a lot to me personally. And I'm very grateful, and obviously grateful for the outcome, and continue to remain positive about the future. So thank you so very, very much to all of you for that. And to the witnesses, thank you for your testimony. I'm from Michigan. 1 out of 10 Michiganders has some form of diabetes. And access to insulin is literally a matter of life or death for those people that I represent. For those patients, there's no shopping. There's no healthcare shopping. They have to be able to access the medication that their doctor prescribes for them. I do support increased transparency in the healthcare system for lots of reasons, but we can't expect transparency alone to rein in the rising costs of healthcare, particularly when there are patients that depend on insulin and don't have the luxury of selecting their treatment based on cost. It's one of the reasons that we passed the Inflation Reduction Act, which included legislation that I helped write to cap insulin at $35 a month for seniors. Of course, we wrote it to apply to all insurances, and we will continue to work to meet that goal. Also, allowing Medicare to negotiate prescription drug prices will make a difference. Taking patients out of the middle, we delivered a real promise of better health care for seniors and millions of dollars of savings. But obviously our work isn't done. The focus of this hearing addresses much of that. But people are still struggling to afford insulin. Patients with diabetes are also struggling to afford the cost of supplies and equipment that are used to manage the disease. And of course, we know there's been dramatic improvement in the delivery mechanisms for insulin. Continuous glucose monitors, the insulin pump, just a couple, and that continues to evolve. So, Dr. Gilfillan, I wonder if you, in your experience at Trinity, in which role you provided direct support to many people in Michigan that I represent, if you might comment on two things. One, on how the cost of these important aspects of diabetes care, the equipment, how managing, making more affordable diabetic equipment would impact outcomes for those 1 out of 10 Michiganders that I represent. But I think important to this conversation also, and Mr. Short, I took note of your testimony where you mentioned the cost of untreated diabetes. So, Dr. Gilfillan, if you might comment on the health outcomes and the cost impact of making more affordable the necessary equipment, not just insulin, but the equipment to more efficiently and effectively deliver that remedy to those patients, what impact that might have on health outcomes and on the cost to not just the federal government, to all those who help underwrite the cost of health care.
Certainly, Congressman, glad to hear your recovery is going well. And I must tell you, I really enjoyed my 5.5 years in Michigan. Wonderful people and good weather for a significant part of the year. Yeah, right. I think, and congratulations again on the insulin coverage and cost. Very important. There were stories, about young type 1 diabetics who were rationing their own insulin and who died as a result of going into diabetic ketoacidosis, the primary complication of that. It's remarkable, and I think it's probably one of the most striking points of evidence about a healthcare system more oriented on wealth for institutions than health for populations, that we allowed pharmaceutical companies to increase the price of insulin the way they have. I mean, it's in any other business, it would be unconscionable, but somehow we allow that to happen. I think the cost of supplies, it's just every element of the system is currently used to optimize revenue and profits for the institutions that operate. And so they use diabetic supplies to exactly that end. And I would suggest the way to deal with that is through a comprehensive coverage program that doesn't have these funny exceptions about DME or other ancillary services, that just says straight up, you get what you need, and make a system of network of providers accountable for delivering those services. The costs associated with diabetic complications is extraordinary. And I don't know the percentage, frankly, of the dollars spent in commercial insurance. Maybe Chris does for diabetic complication, but it's significant. It's probably on the order of 10, 15%, I would guess. So it's a major expense. And I would urge you to get that coverage for both insulin and diabetic supplies passed for the commercial and virtually for all covered populations in the U.S.
Thank you for that. And I thank the chairman for allowing a little extra time. The cost of a CGM or an insulin pump, along with affordable insulin, more than offsets the cost of even a single complication that could be life-changing for those people. So thank you very much, Mr. Chairman. I appreciate it, and I yield back.
Mr. Kildee, we're pleased to have you back in the committee, and 1 minute is the least we could do. But we appreciate you being here.
I think it was unanimous, wasn't it, Mr. Chairman?
It was absolutely. We did it. Mr. Smucker.
Thank you, Mr. Chairman. I'd like to say as well, it's great to see Mr. Kildee here. You're looking great. Maybe better than normal, I don't know. But anyway, Mr. Chairman, I'd like to also thank you for holding this important hearing. And I was a small business owner myself with about 150 employees, and I've seen the value of empowering patients to have as much say as they can in their own healthcare choices, and I've seen how that can help to reduce costs and improve outcomes. And I also developed a real frustration when red tape or regulation, whatever it may be, in our healthcare system got in the way of the delivery of the services or undermined patients' abilities to make their own informed healthcare decisions. So again, this is a great hearing today. I'd like to specifically talk about that in the context of direct primary care, which I appreciated Mr. Blumenauer's comments on that earlier today. It's a bill that we're working on together. And it's important to me because I've seen the impact in my community where different groups, whether it be business owners who are providing the services, have really used this innovative payment model to really make a difference in people's lives. Better access to that primary care when needed, sometimes bringing people or encouraging people to get care earlier, which sometimes can have a real impact rather than letting a condition get worse. So again, I think folks know, but just reiterating, this is a monthly fee that is being paid to doctors for a suite of primary care services rather than paying a fee for each service. So patients like it because they get reliable, high-quality preventative care that keeps them sometimes out of higher-cost sites of care like the emergency room. They also know exactly how much they're going to pay each month for that if it's not being paid for by their employers. But employers like it because investing in that preventative care for employees helps them to be more healthy and also then more productive. And I think in my community, at least doctors like it because that monthly payment structure means they can spend less time coding for services and doing what they really want to do as doctors, spending time caring for their patients. And so this current IRS rule that prevents 32.5 million Americans with a health savings account from participating, from using those funds to pay for direct primary care, I think is something that it's a small fix that I think would benefit a lot of people. And that's why, as I mentioned, I'm proud to work with Mr. Blumenauer. Ms. Tenney, I think, talked about it as well, Mr. Schneider, on the Primary Care Enhancement Act, H.R. 3029, which would fix that gap in our tax code and expand access to direct primary care. The legislation has been favorably reported by this committee on a bipartisan basis in primary congresses as well. So hopefully this is the session that we can fix this. Mr. Short, employers offering direct primary care report savings of over 22% or 20% in some cases. And I wonder if you could just talk a little bit about that, explain how it can both reduce costs and also improve health outcomes for patients.
Absolutely. Even in my company, we offer and pay for direct primary care for the very reasons of savings we've been able to uncover by having the program in place for now over 8 years. And the simple fact is we're able to incentivize the healthcare providers and the direct primary care physicians to take an active role in the preventive medicine of our employees and their families. And by getting them actively involved, where actually their incentive is to keep people healthy versus a fee-for-service world where they make money when people are sick, we have seen the actual results come through in avoiding larger claimants, where diabetes is a great example. If we can get a hold of diabetes first before it becomes an issue with metformin and other processes, we can save money for the plan, and we're seeing that in real life. We saw it in the Milliman study as well, and we're seeing it across the country.
Do you see any reason why patients with HSA should not be allowed to partake in direct primary care?
I see no reason. It seems like common sense.
Yeah, and can you explain why direct primary care it's not health insurance, and the IRS at this point is treating it as such? Can you explain that?
Yeah, so direct primary care is a set of services very focused on primary care, while insurance is a global coverage for multiple things beyond just primary care.
Thank you. Thank you, Mr. Chairman.
Mr. Hearn is recognized.
Thank you, Mr. Chairman, for having this hearing. The first step to making health care more affordable is knowing how much things cost. No industry in America is as opaque as the health care system. It is ridiculous that Americans are in the dark about cost of life-altering medical procedures. And I'm extremely disappointed that my colleagues on the other side have turned this into a partisan issue. The price transparency rules put in place by the Trump administration was a good start, requiring hospitals to post prices on their websites. But unfortunately, most hospitals continue to make these tools hard to find and hard to navigate. There is no reason for hospitals to hide this information from patients. Hospitals are capable of providing helpful price transparency tools. I've seen it in several facilities across my home state of Oklahoma. The lack of price transparency is driving the trillions in spending on the health care in this country. We cannot expect Americans to get the best bang for their buck if they're unable to see the price of services that they're using. Now I want to take some time to clear up some misconceptions that I've heard today. As we all know, over 180 million Americans have private or employer-sponsored coverage. That's more than half of the country. It is critical this committee strengthens these health care benefits not only for the individuals using it, but to alleviate the strain on government programs like Medicare and Medicaid. These programs are ballooning in size, and the people who actually need them are suffering the most. That is the most ironic thing about the Democrats' colleagues today turning into a partisan hearing. Establishing price transparency rules and strengthening the employer market helps the sick, the vulnerable, and the needy. That's why I know this comes down to one fundamental difference between the two parties. We've said it often. Conservatives believe in the consumers and that they can do best with what money they have, not the federal government, who thinks they're better equipped to spend the people's money and choose their. Now let's turn to the slide behind me. This slide has data from where I live in Tulsa, Oklahoma. It shows how premiums, out-of-pocket maximums are significantly lower on employer-sponsored plans accompanied with tax-advantaged accounts. You can see that these premiums are roughly $77 and can be as high as $1,282 on an HCA plan. That's over $1,200 in savings per month. That means something for my constituents, especially in the area of persistent Biden inflation. And when you look at this, you have to look at this and say, we're not here to discredit the ACA. It's here to stay, and after the billions spent, Republicans and Democrats have a responsibility to come together and make it better. But frankly, I'm tired of the other side saying the free market healthcare just does not simply work. That's not true. This chart makes it clear that employer-sponsored care and tax-advantaged accounts deliver savings to enrollees. Lower premiums, lower deductibles, and lower out-of-pocket costs are all good things for Americans, regardless of what state you're in. Regardless if you're a Democrat or Republican, these savings are good and should be looked at. So let's cut it out with the politics, and let's work together to make good policy, price transparency being one of those. I yield back.
Mr. Byer is recognized.
Mr. Chairman, thank you very much. Mr. Chairman and Ranking Member, thank you for putting together this excellent hearing, and thank you all for presenting. I've learned a great deal. And to my friend from Oklahoma, I am confused because I think this has been a pretty bipartisan hearing.
And I've heard virtually no criticism of the idea of price transparency. I think we're all in on that. You know, 8 years ago, Congressman Mike Pompeo and I sponsored legislation on site neutrality for oncology services. It didn't go very far, but it was still a good idea. And we've heard again and again today how much the absence of site neutrality has contributed to the consolidation within the healthcare industry and the rising of prices. But I want to talk about all payer claims database. I introduced the act last session and again this year. And Dr. Whaley, I know you've written about it a lot. We see what it does at the state level in Virginia. APCD recently evaluated the scope of avoidable emergency room visits and also put together a whole price and transparency report based on all payer claims database. Colorado State's insurance uses that marketplace data to figure out its quick cost and its plan finder tool. Can you expand on all payer claims database and specifically the machine readable format?
I think all payer claims databases are fantastic resources. For our study on hospital prices, we've collected data from 11 APCDs, which I actually think is the largest collection of APCDs in a single research study. We've been able to use data from APCDs to highlight variation in hospital prices and other provider prices across states. And with an APCD, you have a lot of confidence that the findings are particularly robust and actually reflecting on the ground the market. As you mentioned, other states have actually gone beyond that. I think Colorado is a very good example, where they've actually set up a separate agency to do studies using the APCD in addition to outside researchers, and then have used the data from that agency called CIVIC to actually inform many of the state policy decisions. So when policymakers in the state of Colorado are making healthcare decisions, they have the most up-to-date and robust data to make those decisions.
Great, thank you. I love the idea of being driven by data. And Dr. Gilfillan, as private equity has expanded into healthcare, what effects have you seen about private equity ownership? And I'm thinking particularly about the emergency rooms that I too often frequent.
Yes. I should note that yesterday, I believe, one of the largest private equity-backed firms in healthcare, Envision Health, filed for bankruptcy under the ownership of KKR, one of the largest private equity entities in America. And that was because, in no small part, because Congress acted in the No Surprises Act to eliminate their business model of balance billing members who end up in an ER through no fault of their own, end up being exposed to a non-participating doctor. Private equity has a short-term interest, call it 5 years, 3 to 5 years, of creating something, driving revenue, and then flipping it and paying it to someone else or getting out. One great example of that, the result of that was in Denver, outside of Denver, a hospital system and private equity joined to open new mini hospitals in local ERs. After a year, they invested, they built these places, they built them up, people started coming, they decided that was no longer their business model, they closed them. The private equity firm just said, you know what, we don't like this business anymore, we're out. And that's the kind of short-term mentality we are introducing into healthcare. The SNF, skilled nursing facility experience mentioned earlier, is another example of the model of buy something with debt, invest as little as possible, charge large management fees, get out of the business when you can, and flip it, and in many instances, mortgage the actual structures and take advantage of that financing. So it's a short-term model. We're seeing it more and more across. We're still seeing it in physician practices. In some of the hospitals I'm aware of, they're still buying anesthesiologists, radiologists, ER doctors, and then going to the hospital and saying, if you don't pay us the rates we want, we will balance bill your members and you'll have to deal with that problem. So there's still that endless march, if you will, of private equity because the trillions of dollars in healthcare are just too much for them to ignore.
Yeah. Thank you very much. And I know I've had a myriad doctors and nurses from emergency rooms in my office complaining that instead of being able to provide care for their patients, they're supposed to maximize profits. With that, I yield back.
Mr. LaHood is recognized.
Thank you, Mr. Chairman, and I want to thank our witnesses here today for your valuable testimony. Like many of my colleagues, the cost of health care is one of the top issues I hear about from constituents back home in Central Illinois. While this committee has made strides towards increasing cost transparency and empowering patients to make their own health care decisions, more obviously can be done. We have an opportunity to come together on this issue and truly help our constituents afford health care services through greater transparency, innovation, and free market principles. During my time on the Ways and Means Committee, I have taken an active role in advancing healthcare policies that improve access, choice, and affordability for my constituents. In rural counties in my district, access and choice to options for healthcare services can be a significant challenge. Additionally, the current inflation crisis underscores the need to give patients more flexibility with how and when they pay for out-of-pocket health care expenses. That is why we should look at many different options, including further support for health savings accounts or flexible spending accounts as a tool for families to make personal health decisions. I have led and supported several pieces of legislation aimed at expanding the use of HSAs and FSAs, including the Dietary Supplement Tax Fairness Act last Congress, with our colleague Representative Boyle of Pennsylvania, and Mr. Kelly's Personal Health Investment Today, or FIT Act this Congress. These bills expand the options for use of HSAs and FSAs, including for preventative care and wellness, allowing for more patient choice in how they pay for health care. I look forward to continuing to work with my colleagues across the aisle to improve our health care system so that it serves all our constituents. When we work together, we can find common ground to create more choices, increase transparency, and bring down costs for Americans. As to a question, Mr. Short, in your testimony, you mentioned the need to address key issues in the healthcare, the U.S. healthcare system, including how the interaction of increased price transparency affects the utilization of HSAs. With that, can you spend a bit more time discussing the relationship between the benefits of expanding tax-advantaged healthcare accounts and how they can support increased price transparency? Thank you.
There's many things that I don't know, but one thing I do know, if individuals don't have the incentive to ask questions, they won't. And tax advantage accounts, including health savings accounts, is a vehicle by which we can actually look at an issue that we're not really talking much about, and that's the inefficiency in payment processing, which is a huge issue in the U.S. healthcare system. So by expanding health savings accounts, coupling with price transparency tools, getting FSAs and HRAs also to be expanded, we'll be able to give more optionality to both individuals and employers, no matter if they're public sector, private sector, and everything in between, to be able to have more weapons to be able to at least ask the question of what things can cost, at least for items that are below the catastrophic deductible.
And what current barriers do you believe have the most impact on patients being able to effectively utilize their HSAs?
Well, a huge barrier is, as we've talked about today, what is the price of care? What does it cost? And I think more and more we can do in terms of price transparency to arm these individual consumers can only be a benefit in allowing for them to deploy their resources as they see fit for the care that they need.
Thank you, Mr. Short. Those are all my questions. I yield back, Mr. Chairman.
Thank you. Mr. Moore is recognized.
Thank you, Mr. Chairman. Ranking Member, I don't say this lightly. This is, in my opinion, the most important thing for our nation to address. We have tried over and over at different tactics and tried different things. And like my colleague from Arizona likes to remind us all, everything we've tried is a financing bill. It's subsidizing the cost from one group to a different group to a different group, and we're sitting here 10, 15, 20 years later, and costs continue to go up. That's the fact. That's the reality. Costs continue to go up. So whatever anybody has tried with respect to healthcare, costs continue to go up. It continues to put small business in the most risky situation because they cannot care for their employees. And that's why I mean this is the most important thing for us to be able to, particularly why I wanted to be on health subcommittee so badly in this committee, because we have an opportunity to do something. And I view this as an opportunity. And I've been a little frustrated today, and I'm going to turn it into a more productive way to communicate it. I cannot hear one more time that because healthcare is different, it's different than a different industry. It's different than getting or choosing a haircut or shopping for a car. I get that. We all get that. We understand that healthcare is different. But that doesn't mean that we shouldn't try to improve it. That doesn't mean that we shouldn't try to actually address the issues that exist. Healthcare is different. There is trauma situations. If I am hit and I'm in the back of an ambulance, no, I am not going to choose and be able to compare prices like I can to go choose a car insurance. We know that. We don't need to be lectured on that. What we need to be able to do is say, what is the aspect within healthcare where we can actually address it? Okay, we all agree, in trauma, in emergency. Yeah, we're not going to. Ms. Triano, have your employees been able to see a lower cost from making a more innovative, like an innovative switch? Your company did it. Have you been able to see lower costs?
We have. Our employees have seen a lot lower costs. Number one, all of their prescriptions are paid for. They can go through online prescription companies now. There are no networks. The insurance company doesn't tell them or tell their doctor what they can or cannot have done. So they have seen lower costs.
Is there a major concern among your employees about catastrophic or trauma-related care? Are they comfortable that they could be covered in that situation?
They are comfortable. They have an insurance card just like everyone else. It's a digital insurance card. You walk in, you present it, and then Sidecar Health takes care of it just like any other insurance company would.
Wait, so you're saying that the concept of healthcare is different because there's emergency medical care needed and you're not going to be in a mental state to be able to make those decisions and choose one haircut place over another haircut place because it's cheaper? You can still address that.
You can still address
We can
that.
still be innovative and reduce costs.
Absolutely, absolutely. And Sidecar Health is very innovative. We've been very happy with what we've been able to do with them and the fact that our employees, doctors, are now taking care of their health care rather than the insurance company telling the doctors what they have to do for that employee's health care.
Dr. Panecki, have you seen similar results, being able to lower costs for your patients?
Absolutely. Yeah, I had the opportunity to speak at a state, Indiana state entity, the Employers Forum of Indiana, and we had just recently entered into a contract with a company very similar to the company and representative here today. It's a company that produces alloys for space shuttle parts, among other things. It's a small company, about 100 to 120 employees, I believe, over 2 sites. And the day that I presented, which was April last month, we were able to save, I think, $50,000 that Friday for that company because there was actually 6 surgeries scheduled. I think 4 of them were colonoscopies, 2 of them were ENT procedures. So the savings is real.
Thank you. Mr. Campine, have you seen an increase in utilization? If you improve your data, Healthcare Blue Book, if you can improve your data, are you seeing an increase of utilization from patients?
Absolutely. Exponential over the years. We're also seeing the similar increases in the savings for the plan sponsors and for the individual members.
Do you think it's worth continuing to go down this path to invest and make sure that we can continue to optimize the data that exists for us to be able to make consumer-based decisions?
Absolutely. We're going to capture more of the dollars that are on the table, and we're going to expand the types of services for which we can capture those dollars. We're not locked in a period not making progress. We've made tremendous progress over a decade, and with the new data that's coming in and some of the new capabilities from the rules, we'll be able to open this up to more services.
And Dr. Gilfin, we have an opportunity, something you brought up earlier, and I agree with you. Lower-income individuals may not be, if we're worried about them being able to make these types of decisions or have access to the information, these innovative solutions can make it so lower-income people can be empowered. So I have to end. Thank you much. I yield back.
Mr. Panetta is recognized.
Thank you, Mr. Chairman. I appreciate that. In my district on the Central Coast of California, I think, Dr. Whaley, you talked about the issues in Northern California. Trust me, I get it. Many providers face that double threat of high government payer rates coupled with a higher than average cost of care. Dr. Gilfillan, in your testimony, you mentioned the impact of payer mix and commercial reimbursement on nonprofit hospital access. Obviously, that drives up the cost of private care, while some providers are leaving the market, are declining to offer traditional Medicare plans to new patients. How can we best address this trend to keep nonprofits with a high government payer mix continuing, make them operate still?
Well, thank you, Congressman Panetta. My belief is that it is
It is wrong. It's simply wrong to pay hospitals differently and subsidize. In effect, we have lower income employees paying for health insurance that then goes to higher rates to hospitals that are in well-to-do communities. It's a reverse subsidization going on. And I believe that we should actually come up with an all-payer mechanism that standardized rates we pay to hospitals so that all communities and their facilities are equally supported. That can be administered through employer insurance or government insurance, and I've suggested in addition a public option, not weakening employer insurance. It actually would strengthen employer insurance. That's the proposal that I would suggest.
Great, thank you. And then as you've heard about the FIT Act that Representative Kelly and I are collating, basically Personal Health and Investment Today Act of 2023, a bill that would allow for qualified sports and fitness expenses to be paid under health savings accounts using pre-tax income. Obviously, the purpose of this legislation is to improve healthy behaviors so people can live fuller lives and stay out of the hospital later on, hopefully. Mr. Short, for the many people who already have an HSA, however, how would allowing this type of income to go toward a non-medical service like youth fitness classes affect people's health?
Well, I think anything that we can do or that can be done to incentivize people to take an active participation in their health is tremendous. And using health savings accounts and other tax advantage accounts to get there is a great vehicle to accomplish that goal.
Great, great. And then, Dr. Gilpin, you mentioned in your testimony the misguided and often counterintuitive strategy of using patient choice as a driver of healthcare savings. In many parts of the country, there are a limited number of health savings operating, and there is a growing trend of doctors leaving the market because of the cost of providing care, as is the case of, like I said, in California, especially Northern California, combined with their cost of living. What would a situation like this mean for a patient with one of the high deductible plans you describe?
Well, I think they're just going to face higher and higher costs. Even if they shop, the costs are going to be higher as a result of increasing market power for those institutions that are in a position to extract those higher rates. And frankly, I think even these innovative insurance plans, I think you need to see a couple of renewals come around because there's no free lunch. The reality is those extraordinary costs are going to get passed back through to the employer, or they're going to get passed back through out-of-pocket spending for employees. So I think some of what we've heard today does not reflect the history of what's happened with these mini-med, minimal coverage plans that actually end up coming home to roost with markedly higher renewal rates or markedly higher out-of-pocket expenses for employees.
Great. Gentlemen, thank you, ma'am. Thank you. I yield back, Mr. Chairman.
Ms. Van Dyne is recognized.
Thank you very much, Mr. Chairman, and thank you to our witnesses. I know it's been a long day. Today's hearing is about access to quality care for all Americans and affordable options for getting that care. 2 weeks ago, I hosted a healthcare roundtable in my district, and I heard firsthand from our current healthcare model that our current healthcare model lacks transparency and has caused people to second guess not only their health care, but how much they're paying for it. And let's be honest, I mean, the fact that patients have absolutely no idea how much they're going to pay for a bill or how much when they start getting the bills, they're going to end up paying for it is causing that frustration. And the cost of health care is skyrocketed, and I'm glad that you're experiencing some relief of that, but it's definitely not universal. We need to work on how our market and how it is structured. I mean, I appreciate what Congressman Moore was saying, that healthcare costs are ridiculous. Here's what I've found. The more federal dollars that we put into healthcare, the more costly it is, the less access people have to it, and quality is suffering as a result. So it can't just be putting more federal dollars in, because every single time you get more federal dollars in, you've got more reports you have to fill out, more red tape you have to go through, and less time you're actually spending with your patients. So, I mean, I look at the costs continuing to rise. I'm like, what can we do to actually help our patients? What can we do to help our constituents? Understanding, and this is a big one that people tend to forget, having health insurance is not the same thing as having health care. Our focus has to be on the care and not just providing insurance companies with more money. So, our country desperately needs pragmatic legislation to reduce these costs and to facilitate long-term savings and revamp our broken healthcare system. So I'm actually proud to introduce innovative, imprudent bills with a hope that my colleagues can see across party lines to adequately address the failures within today's healthcare system. I've introduced a number of bills which would expand HSAs for children, that would add flexibility and would build on the success of HSAs. I know Congressman LaHood had asked you a couple of questions about HSAs, but I want to get more specific if we could. And Mr. Short, do you believe that HSA contribution limits should be updated to help families better afford health care services?
Absolutely. I mean, the rising cost of care is outpaced inflation, so we need to keep up with the contributions to keep up with it to allow families to be able to pay for health care.
When was the last time that they were updated, and do you think that the updates that they have had on an annual basis have been enough to keep up with inflation and actually costs that they're paying out of pocket?
I believe they were recently updated recently by a few $100s, but it's not keeping up with the rising medical inflation we're experiencing.
Do you think that they should be that they should be expanded to include like a children's HSA or an ability to be able to pay for adult parents, perhaps?
Oh, absolutely. Again, any way we can allow for individuals to save and plan and use funds on a tax basis for medical care, maybe for dependents, maybe for elderly parents, is absolutely important and critical and a great step forward.
What do you think are some of the barriers right now that exist that would make them less effective than they could be?
Oh, I think by allowing HSAs for all. Let's get rid of these different insurance mandates. You have a certain type of insurance to be able to have HSAs. Let's have HSA be available for all Americans, regardless to what type of plan they have.
Okay, so what you're suggesting is right now they've got the high deductible health plan. Can you talk a little bit about what that is?
Absolutely. So today you have to have a qualified health plan to be able to contribute to an HSA program. And that just seems counterintuitive that if we allow people to choose the type of plan that works for them and their families, that we can then allow for them to also contribute to the HSA, allowing anybody and everybody that has a plan or any plan or no plan to be able to contribute would be a powerful force into bending the cost curve in the United States.
Do you have an idea of what you think that the HSA limit should be?
I don't, but healthcare is expensive, so the more that we can allow people to save, to be able to plan and pay for healthcare would be critical and important to help out everybody.
I appreciate that, and I yield back. Thank you.
Mr. Feenstra is recognized.
Thank you, Chairman Smith. Thank you all witnesses for coming today. I've got a bit of a conundrum that I need advice and direction on. We all talked about how high healthcare costs is. I don't have to relitigate that. My district is in Iowa. I have the largest agricultural producers in the world. With that, you might imagine that we have vast farmland, open fields, and family-owned farms dotting the roadways. I also have a tremendous amount of rural small communities that have small hospitals. These hospitals are critical access hospitals, and they're operating in the red. So they have to make tough decisions on what services to offer. In March, the University of Iowa published an article in the Journal of Rural Health that found that 1 out of every 5 expecting mothers weren't receiving enough prenatal care after pregnancy centers closed in their area. I wrote my dissertation on this topic and found that there is significant infant and maternal mortality rates because of the lack of maternity care in rural America. This is the issue. When I've talked to hospitals why this is occurring, they said that they do not have the costs. In essence, when you have maternity care, it's a loss leader. They're not profitable. They operate at a loss. So to make them work, they need same-day surgery centers and things like that. However, if we want competition, the same-day surgery center moves in and all of a sudden undercuts the hospital, which then has to close the maternity units. My question is, how can we, and Mr. Whaley, if you could answer this, or advice, how can we create competition, pricing transparency, and yet not have these deserts, maternity deserts, and other rural healthcare deserts that are being caused by the lack of services that are non-profitable?
Thank you for the question. I think, like everyone else on the panel, agrees that we need to keep rural hospitals in business, and those are important and critical providers for people in those communities. And it may require an alternative payment system than we currently have. One challenge, not just for rural hospitals, but I think often for community and safety net hospitals, is that in many cases, in some sense, these are the provider groups that are left out of consolidation. And when providers consolidate, they, in many cases, send higher reimbursed patients and privately insured patients to the system-owned hospitals and facilities. And so if you're a community hospital or a rural hospital, you don't benefit from those privately insured patients that you used to have. And so I think by ensuring that these providers aren't left out of consolidation, by ensuring that we have competition in healthcare markets, then that's one way to provide additional assistance to these providers.
Yeah, that's a very good point, and I'm glad you said that. So how do we handle, and this is really, I don't know what to say on this, and I'm asking your advice, is when you have certificate of need. So in Iowa, we have certificate of need, meaning that you can't have competition in these small communities. What, through your research, what would you say about that?
One of the things we've found pretty consistently with certificate of need, while very well intentioned, many of the certificate of need advisory boards tend to be have lots of existing providers on them, and maybe perhaps not surprisingly, they feel that it's not worth having additional entrants and additional competition. So if we look nationwide, states that have certificate of need actually tend to have less competition, and this includes both with hospitals and also places like ambulatory surgical centers, and higher prices.
Yep, thank you. This is such a hot, big topic in rural America. I mean, we just cannot continue to lose maternity units. And like I said, I've been doing a lot of research on this, and it's scary to me. One other question, my other research, while I was doing the research, also centered around the cost of employees. And this is another thing that, when you start looking, Whaley, at some of your research that you've done, how has the cost of employees over the last several years directly affected the cost not only of competition, but of pricing transparency, meaning that the cost of a surgery one day could be different than the next day because of a third-party price, or third pricing, bringing in nurses, bringing in doctors to these rural communities. This could be quite different, am I right?
It could be, and I think as a potential additional payment model, something like, say, bundled payments, where we've actually seen that the hospital knows how much they're getting, they don't have to deal with insurers, and so that saves them the hassle, and the patient knows how much they're paying, can be one way to have fair and more efficient payments.
Yep. Thank you so much, and I appreciate all your testimonies. I yield back.
Thank you. Votes have been called. We're going to recess for roughly like 15 minutes. There's still a couple members that will be coming back right after the votes to finish the hearing. So please be patient with us. But we'll recess for 15 minutes. The committee will come to order. Mr. Schneider is recognized.
Thank you, Mr. Chairman. And I want to thank you and the ranking member for having this hearing, and our witnesses, thank you for your endurance in staying for the break. But this is a critically important issue. And I hope that there is bipartisan agreement that transparency in pricing would be a good thing. And as I've listened to the hearing over the course of the morning and now into the afternoon, my colleague from Florida, Mr. Buchanan, mentioned that the last decade insurance prices have gone up. Well, I had a business almost 30 years ago, and we had 8 employees. I paid, my partner and I paid everything, but we faced, Ms. Troiano, you mentioned it, we had double-digit percentage increases year after year, and finally had to say we can't afford to do what we had done in the past, and that was, it's hard to say this in the last century, not the last decade. And I like the words Adrian Smith, Representative Smith said, our goal is to empower patients with information. And I know that's what you all are trying to do, but I will say it's somewhat difficult. The other thing I point out is in business, I spent my career in business before coming here. We talked about total cost and had talked about cars here. The lesser quality car might have a lower price, but the cost of operating that car over its lifetime is probably going to be more than getting the better car. The lower price machine tool might save money on day one, but over the course of its lifetime, we're going to spend more money on downtime or defective product defects. I think the same can be said in healthcare. And oftentimes you don't have choices. So, for example, I had a injury to my ankle, traumatic injury to my ankle, and hard to diagnose exactly what happened. I needed a CAT scan, but not just any CAT scan, I needed a weight-bearing CAT scan. I live in Chicago area, lots of hospitals, lots of CAT scans. Only one, though, evidently, could do the weight-bearing CAT scan. So I really didn't have a choice at that. It's hard to make those choices. I also needed an ultrasound on my ankle, which I didn't, before this, know you could do, but it was a very specialized ultrasound. I had to go to one specific technician who had specialized in doing this to help diagnose what had happened with my foot. And I think about it in the context of surgeries, and maybe Dr. Panecki, I'll ask you this question. Minimally invasive surgery, for example, hip surgery. My understanding or guess would be that minimally invasive hip surgery requires specialty operating rooms, special equipment, probably costs more than traditional hip surgery. Is that a fair?
That's true. There's a fair amount more equipment, not just with that specific surgery, but some of the other minimally invasive procedures too require additional.
Yeah, I mean, I have shoulder reconstruction from 1988. That means I'm old, but it also means I have a really large scar, which today would be arthroscopic. We've come far. But if a patient is being charged with figuring out which surgery to get and is using their own funds, might they not go for the traditional hip surgery rather than the minimally invasive that, like that machine tool or less expensive car, is going to have a greater cost over their lifetime of recovery time, possibly follow-up? Maybe you can touch on that. How does a non-medical practitioner like me try to determine what is the best medical decision? Dr. Gilfillan, maybe I'll ask you that question.
It's hard. It's hard because the available data out there is so unclear. And then if you start saying, well, this procedure versus that procedure, you start rapidly getting into the question of complications and long-term, what is the meaning of it? So I think, frankly, that folks become reliant on a physician, typically, or a nurse practitioner in some cases, to advise them on what procedure seems most appropriate. And then they talk to people in the industry to try and get kind of anecdotal guidance about what the best place is to go. Because quality is awfully hard to establish. The immediate quality, complication rate, versus the long-term outcomes of, is this done well so it's going to last me a long time? Very hard to get that information.
Right. So, Mr. Chairman, I wish I could ask you for another 5 or 50 minutes because there's so much to talk about here. But I think the bottom line is, as others have said, we have to bend the cost curve. That is the challenge we face. And transparency is absolutely a piece of bending that cost curve. But as Dr. Gilfillan, you've mentioned, there are so many other things we have to be doing as well. There is no magic pill that's going to solve our healthcare challenges, but we are spending not a percentage more than other developed countries on our healthcare system. We're spending multiples times more, and we're not necessarily getting better outcomes. I look forward to working with my colleagues on this committee and throughout the Congress to find a way to do this, but this has to be one of the most important challenges we face and something we need to find a way to work together across the aisle to come up with ideas and provide the quality health care all Americans deserve, regardless of where they live, and that I know that our doctors and other healthcare professionals want to provide. And with that, I yield back.
Thank you, Mr. Snyder. This is just, price transparency is just a piece in the puzzle that we have to address. You're exactly right. So, Ms. Maliotakis.
Thank you very much. Thank you, Chairman, for holding this hearing today. Transparency in healthcare has become increasingly important. It's an important part of the healthcare system, and I appreciate us exposing what can be done here to not only provide greater transparency, but provide for a more competitive and effective market that will ultimately lead to lower prices for employers, for patients, and for the taxpayers. An area that I've been focusing on is creating more transparency in the way prescription drugs are paid for, and the conflict of interest that exists when one company is the pharmacy benefit manager, as well as the health insurance and the pharmacy as well. The opaqueness that clouds this complex system has made it extremely difficult to understand the prices we pay at the pharmacy counter. Representative Buddy Carter and I have introduced the Protecting Patients Against PBM Abuses Act, which now has bipartisan support, and it would increase transparency on data related to PBM rebates and administrative fees that will help plan sponsors, government agencies, researchers, and the public understand how rebates and fees are impacting costs. In 2019, the Trump administration proposed a transparency and coverage rule. It was finalized in October of 2020, and the rule initially required health insurance plans to publicly post the negotiated rates of prescription drugs within network pharmacies and historical net prices for prescription drugs. However, in August of 2021, the Biden administration paused it and has yet to carry out its implementation. So my first question is for Dr. Whaley. If implemented, what impact would the prescription drug requirement have on increasing transparency in this space to create a more competitive market?
The pharmacy benefit manager, or PBM space, is probably the most consolidated area in the healthcare industry, with 3 or 4 firms essentially dominating the market. And so I think any transparency on the structure of those firms and ownership entities of those firms, as well as rebates, which are mainly confidential, but it's important for employers to know how much they're paying in rebates, would be very critical. And so I think transparency around rebates and pharmacy benefit managers, as well as patient costs for prescription drugs, where patients are actually probably likely to be consumers, would be tremendously helpful.
Thank you. Would anyone else like to answer? I'd like to just know if, Mr. Campeen, if you would like to add to that.
I'm going to weigh in because it was in my written testimony, but absolutely. Understanding NDC allocated net prices is incredibly important. If you're an employer, I always say, look, on the medical side, the carrier network doesn't guarantee high cost or low quality. We know there's a tremendous variability in cost and quality. That same variability occurs within the formulary as well. It's important for employers to know what the net cost is, because that helps them thoughtfully structure drugs after the rebate is accounted for that are most valuable, both from a clinical aspect and from a cost aspect, and so that they are ensuring that drugs with high price and high net costs aren't being put into favorable tiers that patients are consuming, as opposed to other medications that would be more cost effective that are in a higher tier. And so this information is virtually unheard of if you're an employer to actually be able to see this, and it would be incredibly helpful. It will also be helpful in terms of improving transparency for the consumer as well.
I find it very troubling that the pharmacy benefit manager dictates to its competitors, the pharmacists, how much they can make on a drug. Does anyone else find that troubling here? Should there be restrictions so the PBMs cannot also be the insurer and the pharmacy.
I think at minimum, there needs to be transparency in what those ownership arrangements are. And if there is transparency around those ownership arrangements as well as prices, then I think employers can decide whether they're comfortable working with a PBM that owns pharmacies or whether they see a conflict of interest there.
Okay, thank you. Today, just 45% of U.S. 65-year-olds are retired, compared with 58% in 2000. The U.S. Bureau of Labor Statistics estimates that by 2024, a quarter of the workforce will be over the age of 55, and of those, a third will be 65 or more. With rising inflation, higher cost of living, our seniors are certainly struggling to keep up. Mr. Short, how would expanding eligibility to working seniors on Medicare so that they and their employers can continue contributing to their health saving accounts alleviate some of these financial burdens our seniors are facing?
Yes, I mean, having individuals that are Medicare beneficiaries being able to contribute and have HSAs is just basic common sense. Why would we want to give more people the ability to save and plan for future health care expenditures? And it'd be a great step for Medicare beneficiaries to benefit from this program.
Great, thank you very much.
I want to thank you all for a very informative and productive hearing today. We've received many letters of support on the topic of healthcare, price transparency, and without objection, I will submit them into the record. I would also like to thank you all once again for your over 4 hours of questions and answers and testimony on something that appears to be extremely bipartisan, but hopefully we can get some things done. Getting things done in this building is a little bit more difficult than just asking questions in a hearing. But please be advised that members have 2 weeks to submit written questions to be answered later in writing. Those questions and your answers will be made part of the formal hearing record. With that, the committee stands adjourned.